Hello, 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 hello. Hello, everybody. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, July 12th, 2020. It's my birthday. You know, it's so weird. I mean, birthdays are just so strange. Birthday in COVID is even more strange because there's no party or anything at all like that. So, the purpose of my doing these meetings is to make you so strong, so knowledgeable, so informed that no one with you again. I want to give you the knowledge. I want to give you the information. I want to give you the power. I want to give the courage. I want to give you the inspiration to take control of your medical care, take control of your IC, and let's see what we can do to get you feeling better. Thank you, Debbie. Thank you so much. I appreciate it. Debbie from Wisconsin. Hi, Ashley. Thank you. Hi, Annie. Thank you. Thank you. Well, you know, everybody was asking what I was going to do for my birthday, and it's like support group meeting because I want everybody home and safe. I told my entire family we're not going to have a party. We're not doing anything. I want everybody home. I want everybody safe. I want everybody comfortable. I don't want anybody doing anything that would potentially, right? And it's weird. It's so weird. I mean, birthdays are weird anyway, because, you know, as we get older, you know, we start to measure our life and have we accomplished what we want to do and all that sort of stuff. And that's something certainly that I'm doing. So thank you so much for Jeannie. Thank you, Jeannie. Thank you, Deborah. Thank you, Ashley. Debbie is going to have her first cystoscopy on Tuesday. Thank you, Crescenda. Thank you, Gladys. Thank you, Stephanie. Thank you, Lelena. So, Debbie, you're going to have what I call a looky-loo. So, a looky-loo is important. You know, I mean, if you've attended my meetings, you know that I don't like guessing. I like facts. And if I'm in pain, I want somebody to look. And so having a cystoscopy is not a scary thing, in my opinion. It is what I call a looky-loo. Basically, all they're going to do is numb your urethra, stick a cystoscope in, take a look around, pull it out. You're done in 5 minutes. Now, sometimes doctors do other things. They will sometimes, you know, maybe put some medication in there, and you want to make sure that you ask the doctor exactly what they're going to do. They should be informing you of what their intentions are with the cystoscopy. But generally now, you know, just kind of so you understand, back in 1987, when the National Institutes of Health released their first diagnostic criteria for quote unquote IC, which was actually for research studies. So that first NIDDK diagnostic criteria that unfortunately was applied in many clinics around the United States, world, actually was created for the sole purpose of selecting people for research studies. Thank you, Barbara. Thank you, Francine. Thank you, Donna. Thank you, Nancy. So in that research study, what they said is you must have had frequency, urgency, pressure, or pain, a combination of those symptoms for at least 6 weeks. And in those old studies, what they said is to be diagnosed with IC, you must have petechial hemorrhaging or glomulations on your bladder or Hunner's lesions, right? And so back then, you know, you have to understand it was kind of a Mad Max world back then. A lot of people were being diagnosed with IC. A lot of doctors were offering all sorts of different therapies. We didn't have clear standards for picking patients for research studies. What we knew back then is a lot of research studies were failing, and the reason why they were failing is because there were a lot of different patients put into the same study, perhaps incorrectly. And so again, that first NIDDK criteria was specifically for research studies. Now, unfortunately, what happened is a lot of doctors started using it. When they started using it, they told anybody who had a normal bladder that they didn't have IC, right? And that created a tremendous amount of confusion. Now, of course, in 2011, the American Urology Association released their consensus based diagnostic guidelines, which you can read over on our website, icnetwork.org, which corrects all of those issues that we had early on. So, if you, for example, have symptoms of frequency, urgency, pressure, pain, but you have a normal bladder, you're still going to potentially have a diagnosis of IC bladder pain syndrome. It's not excluding people like it was before. But the role of a hydrodistension and a role of a cystoscopy changed. And so in the old criteria, every patient was expected to have a hydrodistension with cystoscopy, everybody. In the new criteria, one of the things that they talk about, how patients have been traumatized over the years. They understand and accept very, very clearly that if you were a urology IC patient 20, 30, 40, 50 years ago, the odds are you were hurt in some way, that you didn't go back, right? You didn't go, if you had a urethral dilation, if you had a variety of painful procedures like silver nitrate or chlorpactin, they understand implicitly that they made a lot of mistakes early on. And so the goal of the new diagnostic criteria is to not traumatize you. Their goal is to do easy stuff first, non-invasive stuff first. And that also is true with testing. They do not recommend hydrodistension with cystoscopy unless your diagnosis is in doubt. So if the doctor is confused, if you've got weird symptoms, if you're getting worse rather than better, if you're bleeding, and we don't know why you're bleeding, why you have urine in your blood, like visible blood clots, that's when you have a hydrodistension. That's when they do it. We don't no longer do it right out the bag. However, getting back to the cystoscopy, the advantage of the cystoscopy, now cystoscopy is not a hydrodistension. Hydrodistensions are done in the OR. Always asleep. You're supposed to be asleep for a hydrodistension because it hurts. Bad. I know this because I had a radiologist do a hydrodistension while I was awake, and I was a screaming lunatic. I walked out of that. They were doing a voiding cystogram, and they made a huge mistake. They overfilled my bladder. She actually got fired over what she did because she specifically ignored my urologist's advice. So hydrodistensions are agony. So you're always under anesthetic for hydrodistensions. However, a looky-loo, a cystoscopy, I've had two. I do it today. If my urologist said, "Hey, Jill, I want to look at your bladder," I do it today. It's not the funnest thing in the world, but on the other hand, it's very quick and it allows them to survey the tissue. And this is why it's important. I want to tell you the story of an IC patient. I've told this story several times in our life support group meetings, and I think it's really, really important. So here we had a patient, fairly severe symptoms for years, unresponsive to bladder therapies, and she was afraid of any testing. She was afraid of any testing. And so they kept trying things and trying things and trying things, and nothing was working. Nothing was working for her, nothing at all. And so finally, she just got to the point where it's like, all right, you can look at my bladder. So they did. You know what they found? A bladder stone, a giant bladder stone. It was obviously a kidney stone that had not passed all the way through, and it had grown over time. It was a calcium oxalate kidney stone. And that's what they do. They grow over time, and they will grow so big that they cannot pass through the urethra anymore. But here's the problem with a kidney stone and bladder stones is that they're very sharp and they're covered with bacteria. They're just bacteria factories. And so in her case, this giant bladder stone was floating around in her bladder, cutting her bladder all the time. You know, remember, your bladder is a small confined organ. Imagine having something very sharp. Every time your urine gets full and down and up and down, the stone is going up and down, cutting your tissue. Well, the great news is with the cystoscopy, they found it and they removed it. And you know what happened? Cured. And she was really kicking herself for not letting the doctor look in her bladder sooner. And so ultimately in the end, it's important that you let somebody look. And the first way you can do that is with a plain cysto. 5 minutes, in and out. The big complication, if there's a complication from a cysto, and it's not even really a complication, it's just that your urethra gets very, very sore. And so the first couple of times you urinate afterwards, it's not going to be fun, you know. Uh, but it will really, within 24 to 36 hours, your urethra is not going to be hurting that much. And word to the wise here, I'm one of those patients where I had a lot of urethral dilations when I was younger, and you kind of learn how to handle those moments. The way I handle the pain and discomfort after cystoscopy is I drink a really big glass of water and try to get my bladder fairly full, but not to the point where I'm crying and in pain. And then when it's time to pee, you gotta just you gotta bite your lip and pee. If you dribble in and out, it'll hurt more. If you just kind of bite your lip and just let it go, it kind of helps open up a little bit. So that's how I handled those. On you for having a cysto, I think it's a really, really good idea for them to look in your bladder, especially if you're not getting better, especially if there is some confusion over what could be happening with you. But Debbie, it's also important to make sure you have a discussion about, are you planning on doing anything else? Are you going to put any medicine in there? Anything like that? You need full information here. We have had a couple of cases of patients having a cysto and then the doctor putting in DMSO afterwards without telling them, and it really hurt them. They were very uncomfortable. And so in the spirit of full information here, I think you have the right to say, can you tell me exactly what you're going to do? Other doctors may do a little bit of a rescue installation, just a numbing agent afterwards, just to chill things out, including your urethra, so that you walk out fairly comfortable. If they're doing a hydrodistension, guys, if anybody is scheduled for hydrodistension in the coming weeks or months, please, 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 please have a discussion with them about what are they going to do if they find Hunner's lesions. Because every week, I swear, every freaking week, I've got somebody calling my office diagnosed with Hunner's lesions. They have the tests, they have the pictures, and the doctor didn't do anything. It's like, wait a second. If you look at the AUA guidelines, it's crystal clear. When you find a lesion, you treat a lesion. You don't send the patient home to suffer. Lesions respond beautifully to lesion therapy. So generally what they will do is cauterize it, they'll laser it, or they'll inject it with a steroid, right? And so again, you got to have that really good discussion with your doctor about, number one, okay, how would I do this? Especially for hydrodistension. Number one, have you done a lot of these? Do you know what you're doing? Number two, have you ever had any issues with any other patients? I'd like to know what my potential risks are. Number three, how are we going to do it? We're going to do it in the OR? The answer is yes. It should be always done in the OR under anesthesia. You should not be awake. Number four, when you get in there, do you have any intention of doing anything? Are you going to do any therapies? Are you going to put any solutions in there? Tell me what you're going to do with my body. It is my body. I want to know. Number five, if you're going to find a Hunner's lesion, if you find Hunner's lesions, what are your intentions there? Because I don't want to lose this opportunity. This is a great opportunity for therapy. I don't want to have another hydrodistension in 3 months to treat it. You're in there. Let's do it. What are your intentions to treat anything you find? And if the doctor says nothing, I would really, really take a step back and go, are you saying you don't know how to treat a Hunner's lesion? Or are you saying you don't have the equipment to treat a Hunner's lesion? Why wouldn't you treat what you find? That's important. And then afterwards, I think you have to really, although you want to have that discussion obviously before your procedure, is understand that while the cystos are really a plain cysto, you're really not looking at major pain. It's not really a pain medication moment, in my opinion. At least it never was for me. But a hydrodistension with cystoscopy could be a pain medication moment. And so you definitely, before the test, you want to have a discussion about pain management. What, doctor, how do you intend to make this more comfortable for me? What will you be doing for me if I have more pain and discomfort after this procedure? What are your intentions here? And for some patients, it's a piece of cake, especially if they're doing a low pressure short duration test, which is much less traumatic. But for others, especially if they overstretch the bladder and really traumatize the bladder, or again, if you have a major therapy in your bladder, you might need a couple of days of pain medicine like Norco to get through it. And so let's see if the doctor's willing to give you a little bit of pain medicine for that. What do you think? What do you think? You guys, thank you so much for your birthday wishes. Let's see here. So I'm simulcasting live on Facebook and YouTube. Let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am the longest serving IC support group leader in the United States at 27 years and counting. How did that happen? In my brain, I am 25 years old. I am not. How old do you think I am today? Any guess? It's stunning to me. I am turning 60 today. It's so weird. It's so weird, especially when I can wear all my sundresses from when I was in my 20s. I think that's hysterical. All right. I have 3 college degrees. I have a degree in chemistry. I have a degree in pharmacology, drug development. I have a master's degree in psychology. The IC Network was my doctoral dissertation proposal on how to bring support to people who were homebound. Unfortunately, I could not finish a doctorate because my IC at the time, my pain at that time was so bad, I could not get in a car and drive anywhere. But I'm very happy that 27 years later, my website, the IC Network, has been rated the top IC website by Harvard Medical School and the University of London for its reliability, accuracy, and credibility. So your first stop, whenever you're struggling with interstitial cystitis issues, I hope will be over on our website, icnetwork.org. We will be doing a Zoom meeting probably in about an hour where you will be able to talk in chat and ask your questions. I don't have any prepared lecture. You just got my little mini lecture on hydros and cystos. Let's just hit your questions real quick. And it's super hot here. It's like over 100. So look at this. I'm totally sweating like, man, whoo. You know what? Hold on. Let me go get a towel real quick. It's a gore. It's just hot, ooh, as you can tell. And I don't want to turn my air conditioner on because you can hear it in chat. But if it gets super bad, I will. All righty then. So I'm simulcasting live Facebook and YouTube. If I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. So let's just go ahead and hit some of your questions. Thank you guys. Thank you so much for your happy birthday wishes. Thank you, Camilla and Lynn and Corrine and Karen and Nancy and Lelena. You guys are sweet. Hey man, and listen, for anybody who's had birthdays by COVID, I hope that you will accept my birthday wishes to you, because this is not a normal life we are in right now. And being home alone without your family and friends sucks. It just sucks. And so I really want you to know that you're not alone, that we're here and we care. We're going to get through this together for sure, 100%. Colleen just posted a hysterical picture of a guy with candles over a roll of toilet tissue trying to blow out the candles, face mask on. That's pretty funny. Thank you, Julianne. Jamie, hydrodistension blows and small bladder blows, but at least they are studying things. And yes, if my daughter would have gone through any of this, she would never have gone back. Her uro took a look at my records, said hereditary and she's doing great with her meds. Yeah, baby, that's what we like. We like success stories. So clearly, Amy, in your situation, we're looking at IC subtype 5, central sensitization. Remember, we have 5 core subtypes for IC. Yes, indeed, there are situations where it is it can be inherited. But the of IC subtype 5, it means that we have inherited a more sensitive nervous system. This is my subtype. Every woman in my family on my mother's side, going back generations, has quote unquote a sensitive bladder. But we also have very sensitive skin. We are drug sensitive. Normal doses of medications are too strong for us. We have to take half doses and pediatric doses. We have food sensitivity. There are some foods that just don't work for us well. Like for me, oatmeal. If I eat oatmeal or chocolate, I have spasms for days afterwards. Kind of makes sense. I'm from Norway. I'm from northern Norway, northern Sweden, where they didn't have chocolate and oatmeal. And those are the two foods that just destroy me from a gut perspective. We tend to have a wicked sense of smell. We can smell things that other people cannot smell, and smells drive us absolutely crazy. We can be visually sensitive. If there's a funky pattern in a carpet or a wallpaper, we have to close our eyes and turn away. We can be sound sensitive, where there are certain sounds. Like, man, if my cat was crying, I could find her. I could hear and find her, even if she was at the end of the yard. It's kind of surreal living with this hyper sensitive body, but it is what it is. And if we go back generations, thousands of years, it was that sensitive person who could find the food, the good food, smell the good food versus the bad food. So being sensitive is an evolutionary priority. It's just very hard in 2020. We have a lot of triggers and stimulants in 2020 that are hard for somebody who has the sensitivities that we do. And so, yeah, we have a sensitive bladder, we have a sensitive stomach, we have a sensitive gut. We're sensitive everywhere. Not a disease. You don't treat it like a disease. It's about calming and soothing nerves. And most people who have central sensitization, even if you don't know the name of it, you're already doing that. You're already doing that. You probably already gotten rid of all the scented candles in your house and the harsh chemicals in your house. So when we look at subtyping and we look at central sensitization, our therapeutic priority is to calm and soothe the nervous system. And the odds are, too, that you're much more comfortable in a quiet environment than a busy environment like the city. I'm much more comfortable in the country, which is where I am right now. Oh, guys, we're having fires every day. Would you believe it? We had another fire last night right over in one of the big burn zones. Thankfully, they caught it early. Woo, but the pictures put it throughout some PTSD for some of us who have already been through those fires. Thank you, Meg. Thank you, Jamie. Thank you, Melanie. Thank you, Marge. Marge has COVID. Oh, Marge, I'm so sorry. How are you doing, hon? And has anybody talked with Dale? Dale was in the support group, one of our live meetings about 3 weeks ago. He too had COVID, and we haven't heard from him since. Lelena says, I'm going to see my urogyno this week and was wondering, how do I find out why my white cell count is always high when doing my yearly blood work? And also, why is it high? I don't know, hun. There is a disorder called eosinophilic cystitis. Eosinophilic cystitis is characterized by having an overabundance of white cells in your bladder. There's also eosinophilic cystitis. I think there's a lung condition that's associated with that too. When we have white blood cells, that means your body's potentially fighting something. I think you're going to have to talk to a hematologist to see if you can figure out what's going on. I wish I knew. I don't know why. Guys, remember, when we're doing these support group meetings, I can't give you medical advice. I'm not your doctor. My goal is to educate you and give you knowledge, and then tell you where to look for things, and then kick you in the butt if necessary and get you back to your doctor so that you can have those important conversations with your doctor. That's what a support group leader does. Donna said, you look great for 60. Thank you. I appreciate that. I'm quite, I thought I'd have white hair by the time I was 60. And you know what? The red hair is kicking it. I am thrilled. It's my revenge for everybody who teased me as a redhead when I was a kid. Now I still have red hair. Yeah. Becky says, I had a great birthday in June. I love staying home and I spent time with my partner and my dogs. Awesome. Joanna says, who do we go to for pain? No one believes how much pain I'm in. So Joanna, boy, that's such a great question. And it really begins with, where is your pain located? It starts with that. Is your pain inside of your body or outside of your body? Okay, so Joanna is over on YouTube. Joanna, if you could answer that question, we can go from there. All right. And so let me go back to Facebook here. Janet says she's had a bladder infection for 6 months and nothing is helping. So Janet, your goal here now, listen, you've had an infection for, we need to prove it. It's time to prove it. You prove it. This is the way you prove it. You have a next generation urine test. Go to bladderhealth.org. There's a whole bunch of videos of doctors who use it. This is how you figure out the type of infection you have, if it's drug resistance, and it will give you the recommended therapies for that infection. All of the new major research studies done with IC and done with COVID and done with so many other conditions are now utilizing next generation DNA testing. We're no longer necessarily using simple urine tests because they don't isolate enough. A urine test will only isolate 5% of the bacteria that this will isolate. And more importantly, it will also tell us if you potentially have a fungal infection. So this is what you do. We need to know the type of infection. Guys, listen, anytime a doctor says, hey, you got a bladder infection, your first question is what type? And they say bladder infection, and you say, no. I want to know what type. What's the bacteria? Is it E. coli, staph, strep? That's critically important. You've got to track the infection. If it's the same infection over and over and over and over, then you either have a super drug-resistant form of infection, E. coli, for example, or you've got something in your daily environment that's constantly re-inoculating you. Like, for example, a bathtub with jets that have been installed incorrectly. A jet on your bed, the things that put the air in your bathtub or in a hot tub. Jets are supposed to be installed at a downward angle so that they drain out. If your jet is installed straight or slightly upward, the water pools and it won't drain out and it becomes a bacteria factory, and that is proven by the Center for Disease Control. So again, if you're having the same infection over and over and over again, it's either a drug-resistant form of the infection or you have something inoculating you, or you could be menopausal. It's so weird. It's so weird to it's so weird when you feel so young inside that you're dealing with older issues. If you have estrogen atrophy from menopause, what that means is that your bladder doesn't have as much mucus as it normally has that acts as a barrier that makes it hard for bacteria to infect your bladder cells, So remember, your bladder is like your mouth. It is a hollow organ covered with a really thick, robust coating of mucus. And that mucus acts as a protective barrier. It makes it hard for any irritants in the urine to reach those cells and irritate you. But even just as important, it makes it hard for bacteria to infect you. However, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus. When you're older, you have much less estrogen, much less mucus, and there is a significant population of women who get recurring infections over and over and over again, like literally every 2 weeks, every month, a new infection proven by culture or proven by next-gen testing. So I attended a class at the American Urology Association. I think it was at the AUA. It could have been at an NIH meeting by Dr. Anthony Schaefer, who talked about recurring infections in women. And the first thing he said is, number one, we never diagnose them with a simple infection. It is always considered a complex infection. Number two, they've done extensive testing with these group of patients. They will do urine samples every day. They will do vaginal swabs every day. They have done massive research trying to figure out why you have infection all the time. And what it always comes down to is they find it in the vagina about 24 hours before it arrives in the bladder. And that made the researchers ask, well, what's happened to the vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer comes right back to estrogen atrophy, because your vagina also relies on estrogen to produce mucus. And so when you have less estrogen, you have less mucus. So your vagina becomes a safe port in the storm for bacteria. You also have changes in pH, which favor bacterial growth in the vagina. So, Jana, one of the things that you can do is prevent. Prevent is like Allura. And so, remember the kind of old wives' tale that cranberry juice helps with infections? Well, that's true to a certain extent. Cranberry juice, specifically the proanthocyanidins, PCs in cranberry, can help flush E. coli bacteria out of your body. Cranberry juice by itself is very acidic, very irritating for most of us. We can't drink cranberry juice. But if you're somebody who is struggling with recurring infections, normally a doctor will recommend either Allura. Unfortunately, Allura is very expensive, or Prevent, which is half the price, which is proanthocyanidins and D-mannose. And this would be a really, really good thing to potentially try and talk to your doctor about, okay? Is it Eve? Yeah, I'm not sure how to pronounce your name, Eve, but she says she had a hydrodistension bladder installation during the cystoscopy. It gave me relief for 3 months only, though. So that's not at all surprising. When you have a hydrodistension, that's kind of like a destructive therapy. The reason why people feel better after hydro is because it temporarily breaks the nerves. And so you feel good because the nerves that give you the frequent surges pain have been stretched and broken. And so, yeah, you feel better. But guess what? They grow back, and sometimes more grow back. So a hydrodistension as a therapy is really not recommended so much anymore. It's what we would consider a destructive therapy rather than a constructive therapy. Okay, I want to go back to, hold on a sec. God, you guys are talking so much. So I'm going back to Joanna here. So Joanna on YouTube says, who do we go to for pain? No one believes how much pain I'm in. And I asked her, where's your pain? Is it on the inside or on the outside? So we know her pain is on the inside. So now, Joanna, this is what I want to know. Oh, wait a second. She says, I've been told that I have pelvic congestion syndrome. Oh ho, oh ho, oh ho, oh ho. Hold on. All right. So guys, when you're struggling with pain and you're looking for relief, you are really an anatomical mystery to be solved. And what do I always say? When you go to a doctor, please don't walk in and say you've got interstitial cystitis. That is a mistake, because you fall down the icy rabbit hole of whatever training or beliefs they have. Your goal is to get them to focus on your anatomy. You need them to study your pelvis, right? And your ability to describe your symptoms is going to play a critical role in how successful that first appointment is. And it's really amazing the number of patients who struggle with words. Okay, and so as I kind of walk them through it, it's like, okay, here are my questions. Is it inside of your body or outside of your body? You'd be amazed at the number of people who's on the outside, because that's usually estrogen atrophy. So the next question, is it centered, or is it to the left or right of center? So Joanna, is your pain under your belly button but in a straight line down, or is it to the left or right? Okay. The question after that, is it low or high? Is it low down by your pubic hair, maybe down by your urethra? Or is it really up higher? Is it up by your belly button? And then what does it feel like? Is it sharp or dull? Is it electrical? Do you feel like you're being shocked like by an electrical stimulation? Do you have shooting pain down a leg? Or is it dull and burning? Okay, so Joanna, now I want you to try to describe your pain for us. Okay, so she says her pain is centered and to the left, and that it is low, and that it is burning and dull. So bladder wall pain. Now remember, my friends, your pelvis is a very busy part of your body. Your pelvis is the center of the human body. It carries the weight of your torso. It deflects the stress and forces when you walk and run and stumble, because all those muscles and ligaments all move right back up into your pelvis. Your pelvis is a communication channel. It is where the nerves from your spinal cord go through down to your legs and feet. It is where blood vessels from your heart go down and go through to both legs and to your feet. And of course, your pelvis has organs in it. If you're a woman, obviously it's got your reproductive tract. We know it's got your urinary tract, and we got your bowel. So it is a very small, confined area. Come on, guys, it's this big, and it's got a lot of stuff happening there. The mistake in Western medicine is that specialists stay in their box. They don't explore interrelationships so well. So if you go to a urologist, they're going to focus on your urinary tract. If you go to a gynecologist, they're going to focus on your reproductive tract. If you go, because you've got bowel spasms, to a gastroenterologist, they're going to look at your gut and your bowel and your rectum. They pretty much suck at connecting them because medical schools didn't teach them so well about how they connect with each other. But one of the things that we do know is that the nerves for all of these merge at the spinal cord. And so we have something called neurocrosstalk. We now know that, for example, if your bowel gets irritated, your odds are your bladder's probably going to be irritated too, and vice versa. So exploring these relationships is important. So let's get back to pain. Pain is sharp and shrill. It's described as ribs and ground glass. And here's a picture of petechial hemorrhages. So let's do this. This is a Hunner's lesion. These are Hunner's lesions. So look, you can see this is a big wound, right? Big wound. It's a stellate appearance. It's got arms extending from it. Obviously, urine in this wound is going to hurt like hell. So these patients do not describe it as burning and dull. This is sharp. It feels like you're being sliced by something. This is petechial hemorrhages. So this is the equivalent of more of an injury to the bladder wall. And again, as your bladder fills with urine finds these wounds. And again, we're looking for intense sharpness, not burning and dull. Burning and dull points us more to muscles. And burning and dull points us more to, as you just said, potentially pelvic congestion syndrome. So when you go to a doctor and you're getting them to study your pelvis, they got to look at everything. They got to look at blood vessels. They got to look at nerves. They got to look at organs, et cetera, et cetera. Joanna has pelvic congestion syndrome. And guess what, Joanna? The lead story in our magazine, pelvic congestion syndrome. So pelvic congestion syndrome is the equivalent of very large swollen varicose veins in your pelvis that throughout the day start to pool blood. One of the things that, as a support group leader, always baffled me is that some patients described a sensation like they were carrying a bowling ball around in their pelvis. And that actually is that heaviness, that pressure, that bowling ball sensation is actually potentially swollen veins. That's how pelvic congestion syndrome worsens throughout the day. You might be fine when you wake up, but as you proceed during the day, you get fuller and fuller and fuller, heavier and heavier and heavier until at the end of the day, bam, you just have to lie down. And then, of course, by lying down and by going to sleep, the blood moves around. The blood isn't pooling so much anymore in your pelvis. So Joanna, you might find this article interesting. Because urinary frequency urgency is common with people with pelvic congestion syndrome. The cool thing about pelvic congestion syndrome is that it is very easily treated, and that when you treat it, the bladder symptoms and that pressure often goes away. So that would be number one, Joanna, is we got to figure out what's going on with your pelvic congestion syndrome and should it be treated. But the second thing she talks about here is that she had a hysterectomy for endo. So when did you have that hysterectomy, Joanna? When did you have the hysterectomy? Hysterectomy is incredibly traumatic to muscles. And it's not at all unusual for patients to have scar tissue, for patients to have adhesions, which is the same thing, kind of, sort of, and pelvic floor spasms after hysterectomy. So, Joanna, have you had a pelvic floor assessment? It'd be very interesting to see what the state of your muscles are. A muscle that's working hard is a muscle that burns lactic acid that causes burning. She says she's not had one. That's your first stop, hon. You need a proper pelvic floor assessment. Burning is often associated with very tight muscles that are in a tension pattern that are producing lactic acid. And it would be really useful for you to, and I say this to everybody, hey, listen, if you've had your birthday, here's your birthday present. It's free on Kindle Unlimited. Come on, guys, it's free. Best book ever written on pelvic pain and pelvic injury. This is a fantastic book, Breaking Through Chronic Pelvic Pain. This will teach you more about the pelvis and all the interrelationships in the pelvis that can be triggering your bladder symptoms. In many cases, the bladder is the secondary victim of another issue. If you have fibroid tumors that are pushing on the bladder, the fibroids are the primary problem. The bladder is the secondary problem. If you've got pelvic congestion syndrome, the same thing. If you are recovering from hysterectomy, you got super tight muscles that are compromising the bladder, restricting blood flow to the bladder, and damaging nerves that support the bladder, and the bladder wall starts to break down in a somatovisceral reflex. For those patients, guys, I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved. They cannot not both be involved because they are so incredibly interconnected. And so if you have bladder pain, I can tell you your muscles are tight in a guarding reflex. That's the way it works. It is subconscious. You cannot turn that off. Anytime you're in pain, the muscles in the area get tight to protect you from that pain. So we know that organs can change muscles, because if your organ is screaming in pain, the muscles in the area are going to get tight to protect you from that pain, right? There's no doubt about that. That's proven. But the really important question is, what about the opposite? Can a muscle change an organ? That's called a somatovisceral reflex. And Dr. Weiss, in his book, explains exactly how that is. But in the IC patient world, now listen, we're not all the same. For some patients, IC begins in childhood. For others, after menopause. For some of you, it began after having a baby or a rape or a car accident. While for others, it began, after chemotherapy. We're not the same in any way, shape, or form. You are an anatomical mystery to be solved. Now, if you're a chemotherapy patient, we know the chemicals of the chemo are damaging your bladder wall, and your bladder is screaming, help me. My God, stop pouring acid on me. It hurts, it hurts, it hurts. And your muscles are getting tight to protect you. The same is true for people who drink a lot of soda every day. Your bladder's not designed to handle acid all day, every day. The bladder wall is vulnerable. If you pour acid on it every day, it's going to start screaming. There's no doubt about that. Our therapeutic priority for the chemo patient or the diet patient is to calm and soothe the bladder. When we calm and soothe the bladder, we know the muscles will release. But that's the smaller group, guys. The bigger group are patients whose symptoms began after a muscle injury. Did your IC begin after a fall, after a trauma, after a car accident, a history of athletics? Were you an ice skater, a gymnast, a wrestler, a football player, a bike rider? Pelvic floor trauma, especially tailbone injuries, consequences. It will influence the bladder. It will influence the health of the bladder. But here you go. So you have no clue, right? One day you wake up with frequency urgency, or you experience frequency urgency. You call your doctor. Hey, doc, I got a bladder infection. Doctor goes, here, have some antibiotics. They don't work. You go back to the doctor. Doctor goes, oh, let's culture it. Your culture comes back negative. Doctor gives you antibiotics anyway. They don't work. You go back to the doctor. Doctor goes, well, maybe you've got overactive bladder. They give you ditropan, Detrol, smooth muscle relaxants. They don't work. You go back to the doctor. Doctor goes, you know what? You must have ICO. I'm so sorry. Having IC is awful. I'm sorry. They give you IC meds. They don't work. You go back to the doctor. Doctor, nothing's worked. You spend years on bladder therapies. Doesn't work. Why? Because behind the scenes, you probably also have a muscle problem. So for these patients, the reality is bladder-specific therapies will never fix it. The therapeutic priority for the pelvic floor patient is to restore blood flow. Because if you've got tight muscles, blood flow is restricted into your pelvis and to your bladder. So how do we treat that? We're going to treat that with muscle therapy. Pelvic floor physical therapy. And our goal here is to get these muscles normal again. So I use this as an example. So here's your pelvic floor. Now this is not an anatomically correct example, but let's just say your pelvic floor has gotten tight. What they do is they will work to try to get the correct length and consistency of the muscle. Their goal is this is a good example for the piriformis muscles, which are kind of like this, right? So they will go in and they will try to get them their proper length and consistency. We don't want them hard. We want them soft and pliant. And we know pelvic floor physical therapy outperforms many bladder therapies. In a proven National Institutes of Health IC research study that was released in 2008. And when that study came out proving that pelvic floor physical therapy was more successful than most bladder therapies at reducing pain, that turned the IC world on its head. Because up to that point, everybody's going, but this is a bladder disease. And the thing, though, was if this is a bladder disease, why does muscle help? Annie is trying to give us stars on Facebook. It says the person needs to send you a 4-digit code before you can give stars. I think you have to authorize it in Facebook, hon. It's not something that I put out. People have given stars before. Guys, if you find these meetings really helpful, one of the things you can do is you can subscribe and become a member and get our magazine. You can make a donation. That would be great. Obviously, this meeting is free and I don't go back and check. Or on Facebook, you can give us stars. See, Julianne just sent 200 stars. So that means that you just have to finish your star setup. All right. So let's get back to the muscle injury patient here and Joanna here. Joanna has centered pain and to the left of center, and it's low. So anytime we have pain that's to the left or right, we're always potentially looking at muscle. We're not looking at the bladder. We're looking at what is in that location, which is usually muscle, although it can be other things too, like endometriosis, fibroids, things like that. And now any good urologist at your very, very first appointment would be doing a pelvic floor assessment, because we need to know what the health of your muscles are. And you need to tell them, hey, you know what? My pain isn't always right here. Sometimes my pain is over here. And go to your gynecologist and see if they'll do that for you, or go to your urologist and see if they'll do that for you. Because, between the hysterectomy and your pain and the pelvic congestion syndrome, your bladder is probably a secondary victim of one of these other conditions. Hello, Gigi. Thank you for your happy birthday wishes. I appreciate it. Suzanne, thank you for your happy birthday wishes. Brittany, thank you so much. Julianne, thank you. Thank you. Gigi says, no way, you're older than me. It's so weird. Marion says, happy 60th. Thank you. Thank you. You guys, thank you for your stars. Thank you, Sherry. Elizabeth says, you look in your late 20s to early. Hey, listen, that's with makeup. Just seeing you without makeup. Thank you, Terry. Carol says, my daughter has been told she has IC. However, her doctor has been treating her with nitrofurantoin for months and still having issues. She's now 24 and has started bedwetting on occasions. She feels absolutely nothing. Has to get to the bathroom immediately when she has to urinate. Sometimes it gets urine to run down her leg. So are these symptoms normal? No, the answer is, oh, hell no, those are not normal. And again, that speaks to muscles or nerves, hun. Listen, frequency, urgency, pressure, pain. What the hell does urgency mean? Urgency means you've got to go. Like you're fine. And then all of a sudden, oh my God, I've got to go to the bathroom. Oh my God, I have to go now. The question is, what is driving that sense of urgency? If you're running to the bathroom because you're worried you're going to leak and you don't get to the bathroom in time, that usually means overactive bladder, which usually means there might be a nerve issue going on or a muscle issue going on. But if you're running to the bathroom because you're in pain and you're going to the bathroom to reduce pain, that points to injury, trauma of the bladder wall, or something going on directly with the bladder. And so that's how we distinguish between overactive bladder and IC, is what's driving that urgency. So, Carol, I don't know what state you're in. This has gone on way too long. She's been on an antibiotic for months. It's not helping. The bedwetting is concerning, certainly embarrassing for her. And so I think it's very, very important at this point in time to get a second opinion and maybe go to an IC research center, because, and also too, hon, listen, the proof is in the pudding here. The doctor is giving her antibiotics saying she's got infection. Prove it. Have a next generation urine test. This is something I would do immediately. You can order this yourself. It's $199. Go to bladderhealth.org. The company is Microgen. There are a couple of companies that do it. This is just the company that we've worked with for years. So you just order it. They will send you the kit. You pee into a cup. They take a little tiny bit of urine. You take the form to your doctor, get your doctor to sign it off. You send it back. And this will identify any potential pathogen. Because they'll tell you there are patients who have been on antibiotics for years only to discover after the fact they never, ever had infection, that it was a muscle injury or something else going on. Listen, the bladder only knows one language, my friends: frequency, urgency, pressure, pain. You could have a bullet wound and it would feel like infection. You could have a stab wound and it would feel like infection. The only language that the bladder has to tell you that there's a problem is with frequency, urgency, pressure, pain. So it's not always infection. It could be a structural problem. So anyway, the proof is in the pudding. If he says she's got an infection, let's do it. Do a next generation test. It'll tell you the type of infection. It'll tell you if it's drug resistant, and it will give you the right antibiotic therapy, because clearly that antibiotic is not correct if she has infection. But I want to know what the hell's going on with her muscles and or nerves. she should have a pelvic floor assessment. That's important. Any good IC doctor would be doing a pelvic floor physical assessment at the very first appointment to make sure the muscles are healthy. And the fact that she's bedwetting, again, that either points to muscle issue or to nerve issues. Carol, out of curiosity, was your daughter an athlete? Did anything trigger it? You go back in time to when her symptoms began. What does she think started it? And by the way, I'd love to talk to you and love to talk to her this week. If you guys would like to give a phone call, I'd be more than happy to talk with you. Hello, Helen. Dale is here. Dale, you have been on my mind. How are you? Dale had COVID. I haven't heard from you in 3 weeks. I was worried. How are you, Dale? Would you tell us? And I know I'm like 35 minutes behind on Facebook right now. I'm sorry. I'm getting through it. Sherry, thank you. Those came from a very good friend of mine and his wife. It was wonderful. Hello, Brenda. Thank you, Brenda. Gigi says, finally got my records for when I took my Elmeron. What do I do next? I had photos taken of both my eyes. Now you got to contact a law firm. Yeah, you've got to contact a law firm. And we have been working with a couple of different law firms. So you just go on over to our website, network.org, and you can go into the latest blog that talked about the new FDA warning for Elmeron. And we have the list of the attorneys at that time. And then I have a new firm that we're starting to work with too. Now law firms are grouping together in big groups, and which is a good sign because they're now pooling resources so that they can pursue more aggressive litigation. So now the first group of attorneys have asked for assistance, et cetera, et cetera. Thank you, Heather. Thank you, Rhonda. Dale says, I'm over the COVID, but I'm still having shortness of breath. My doctor said I'm getting better and the symptoms may linger for 3 months. My eyes, oh, Dale. Oh, God, you seriously, dude, I just want to cry. I was so worried about you. I'm so glad you're better. Oh, like seriously. Oh, you're the first IC patient that I worked with COVID, you know. I've been thinking about you like mad. Oh, okay. These are birthday emotions too. Okay. Hi, Kay. Thank you. Annie gave you 250 stars. Oh, thank you, Annie. Kay says, first hydrodistension, the doctor put DMSO in my bladder with a chipped off catheter. So when I woke up, I was in horrible pain. I told them you do not put DMSO in after a hydro in the operating room period. What do you think about that? We certainly know that certain medications would never be put in the bladder after a hydro, specifically silver nitrate or chlorpactin, because when you have a hydrodistension, there's always a chance that the bladder wall can be ruptured. And so if you look at the early treatment protocols for silver nitrate or chlorpactin, they're very, very clear that these would never be used after a hydrodistension because of the risk that the medication could leave the bladder, go into the belly, and cause serious problems. I don't think that I have seen the same warning for DMSO. I don't think I have. So now, again, normally DMSO is done in a cocktail form with some heparin, some lidocaine, some steroids, stuff like that to be hopefully calming and soothing. So if it was done with that intention, that's explainable. What's not explainable is that they used a damaged catheter, a chipped off catheter that could have torn your urethra, or maybe if they put it in too far, damaged your bladder. I'll tell you one really interesting case happened in my local support group. Fascinating. And she is unfortunately no longer with us. No, 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 no. I'm confusing patients. No, no, no. Sorry. Hold on. Different patient. I had one patient, her name was Linda, who went into a coma. And I sat in ICU with her every day for a week, and we eventually lost her. The other patient, though, was doing self-cathing, and she put the catheter in too far, and the entire catheter slipped into her bladder. And she ended up at the emergency room with a catheter stuck in her bladder. It had gone all the way through, and they had to call a local urologist to try to get that catheter out. So, guys, if you're self-cathing, your urethra is only about this long. You only have to push it in about this far. You don't push it in this far, which she did. Donna, yes, Dale is okay. He is back on Facebook. See, Dale, people are asking about you on YouTube too. Lorraine says, getting over a bad flare, feeling much better, but a lot of burning. What can I do or take for a burning bladder? Well, that might be more useful if you aloe. We have a new aloe product that's coming out. Hopefully, I'll have it later this week, called Aloe Path, and it's going to have aloe and PEA in it to be especially calming and soothing. And so that would be, you could do that, but you could also do Azo bladder pain relief tablets. Just found a new distributor for Azo. Hallelujah. But so you could do Azo bladder pain relief tablets. That would help reduce some of the burning. Of course, hydrating. You don't have to drink a massive amount of water, but don't stop drinking water because you don't want your urine to get super concentrated. And so try to keep flushing your bladder, but please don't drink alkaline water all day. That would be a mistake. That would be very irritating. All right. Somebody just came in and has called me auntie. Okay, thank you. I consider that a compliment, but I have 2 nephews and you're not one of them. But thank you. Eve says her pain is internal, dull, and burning, really low, center, left, and right. My doctor thinks my endo is coming back. That's possible, but look at the muscles too. Because when you have endometriosis, you're in a lot of pain. Your pelvic floor muscles will get tight. And so it could also be tight muscles that are just stuck tight, even though your endo might be okay. You got to rule both of them out. All right, let's go back over here to YouTube really quick. Hi, Sherry. Tammy says, I had a hydro done 2 weeks ago and I'm in worse pain. I think my doctor really just didn't get it. A male urologist didn't communicate with me. You hurt for weeks longer than you should after any. Oh, wait, no, that's Joanna. Hold on. The procedure used to work well for me, not the last 2 times. I came home with more pain and more urgency. I'm in so much pain right now. So, Tammy, remember, listen, you've had hydrodistensions before. That the most common side effect or complication, no, side effect is the wrong word. The most common adverse event complication of hydrodistension is a nosocomial infection. If you find that your symptoms get worse rather than better after a hydrodistension, the odds are you could have picked up a infection. And so you always need to get that checked. And remember too, hydros hurt. And so your muscles could be tight too. So you could be having pain. Tammy says, how is the Elmeron administered? The Elmeron for the eye issues is oral, but they can also do rescue instills where you do not get the systemic distribution, including to the eye. So any topical installations are considered much safer than systemic oral therapies. Thank you, Donna. Donna just summarized that perfectly. Thank you. Hey guys, let me go start the Zoom meeting. Now, what we do is we pull up Zoom, and on Zoom, you guys can come into Zoom and you will be able to ask questions yourself. And YouTube and Facebook will still be live. They will be able to hear your question. And so privacy is important. Don't do it. But if you don't mind sharing and asking questions, you can come on into Zoom and let other people see your face. And of course, Facebook and YouTube won't be able to see it, but the people in the Zoom meeting will. So Sometimes we get a lot of people in, sometimes we don't, but let's open it up and give it a shot. So give me a moment. And guys, have a drink. All right, I'm going to start this meeting. And let me start the video. Woohoo! There we are. Oh, man, you can tell it is hot and sweaty here. I am hot and sweaty. All right. So so hold on a sec, guys. Let me just go back to Facebook here for a moment. Patty says she got the book, found it super helpful. Donna says, what do you think of microgen testing? I love it. I like facts. I don't like guessing. It's good information. It's affordable. If it finds that you have infection, then we know what to do. If it finds out what type of infection it could be, including a fungal infection. And if it doesn't find anything, you can move on and walk away from all of your infectious therapies. All right, so hold on a sec. Let me get the invite here. Copy invite link. All right. All right. So oh my God, I've got so many windows open on my computer. Okay. All right. YouTube, you're getting the invite first. Facebook. Now, Facebook, just know that sometimes I can't go back and look at your messages. So don't take it personally if I missed one of your messages. Just ask it again. Carol says, steroid injections into Hunter's lesions, the only thing that works for me. Awesome. Okay, Brittany says, my symptoms started a week before I turned 30, about 4.5 months ago. I'm having a hard time accepting this new reality. I feel like I'm too young for this. Although that's not true, no one is guaranteed. I just wasn't expecting this. I'm worried that it might affect me. Girl, now listen. Now, Brittany, listen. I don't want you to think of it that IC is an old lady's disease. It's not. It's injury. It's trauma in many of us. The majority of patients that I work with are in their 20s and 30s. And so you've got to go back in time and we have to try to figure out what triggered your symptoms, hon. I mean, it happened to me when I was 32. It's okay. It's okay. We'll get through it. We will figure it out. Maddie says, our magazine, The Icy Optimist, is great. Awesome. I tell you, Stacy and I work on it like mad. Okay, I'm scrolling down. So Facebook, you guys, you're getting your invite. Sorry. There you go. And Donna and Lisa are already in the meeting. Let me move this. Hi, Lisa. Hi, Donna. I can only see the top of your head. Oh, because of your face. There you go. Hi, Donna.
Okay, we gotta fix that then. Hi, baby.
Hi there. Okay, you guys, we're just gonna let some more people come in so you guys can hear. You can talk. Guys. Okay, listen. While we're waiting for people to come into the Zoom meeting and Facebook, I'm gonna go ahead and post the link again. Please come on in if you want to come on in. Okay, Julianne's coming in. What's going to happen is you're going to be put into a waiting room, and then I'm going to let you in manually. So Julianne's in now. Help. The answer is pumpkin seed oil has been found helpful for prostatitis, but not so much for IC. The last time I looked at it, I remember being American Urology Association meeting where they were presenting the data for pumpkin seed and prostatitis. For quote unquote IC bladder wall, the critical ingredient here really is going to be chondroitin. The supplement, if you got a bladder wall issue, the supplement that has been found to help restore the integrity, the surface integrity of the bladder wall, the urothelium, is in fact chondroitin. So you want to do a chondroitin-based supplement, which is going to be so the supplements that have the most credibility are going to be Bladder Builder, Bladder Rest, Cysto Protect, and Cysto Reno. All right, hold on. Okay, well, it's going to be a small Zoom meeting, but that's okay. So, hey guys, before we get started, I went, hold on. I got to open up a new window. Did you see our discussion about IC Awareness Month on Facebook and the possible slogans that we came up with? Donna, Donna, are you on Facebook or are you just on YouTube? So hold on a sec. I want to bounce this off of you guys real quick. So give me a second here.
Hey, Jill?
Yeah.
I'm just on YouTube.
You're just on YouTube.
I can be on Facebook if you need me to be.
No, well, no. Just hold on a sec, guys. So listen, we got 50 people watching. And so, guys, let's just decide. I want to decide right now our slogan for IC Awareness Month. And okay, and here we got somebody else coming into YouTube on an iPhone. Coming into Zoom. All right, so I don't know if anybody else on Facebook saw this, but let me just go over this real quick. I got to find it. Hold on. I'm running a lot of software on my computer right now.
Hey, Lisa. I don't need to get up turn. Hi, Julianne. I know you don't love doing this. I didn't do my job to press the define you, leaving you with zero commitment.
Okay, guys. I need your help. So we gotta create our slogan for IC Awareness Month. We had a very nice discussion on Facebook about it, and I was thinking something that caught me was, and hold on a sec, we can hear somebody, so let me just mute. Okay, Donna, you're unmuted. That's okay, but I had to mute somebody there. So something that sounded good to me for IC Awareness Month, instead of like we stand together or like that, how about, now this is one of several, your story is important, your voice matters.
That sounds good.
That's not bad.
Sounds good.
Okay, but there's more. Here's another one. Your pain is real, your voice matters. Okay, here, hold on. I'm letting Barb in. Your story is important, and so is your voice. Let's join hands. I see pain, IC matters, or IC pain matters. Uh-oh. Lorraine, I tried to just, Lorraine, please try to join again. I might have accidentally disconnected you. It wasn't intentional. Lorraine. I'm sorry, Lorraine. Try again. Go into Zoom again.
I'm in Zoom.
Are you there? Okay. Your voice matters, your pain matters, your journey matters. Now give your pain a voice. Pain is real, IC is real. What
was the first one?
Or see the pain. Ooh, I see. See the pain, support the challenge.
Hey, I like that.
Ooh.
That's kind of catchy. See the pain, support the challenge.
Yeah.
Hey, not bad.
That's
not bad.
That is
not bad. Not bad. That's not bad at all, Jill. That's pretty darn good so far.
See the
pain, support the challenge. Interesting.
See the pain, support the challenge.
Interesting.
I just don't know. I just don't know what support the challenge means. What does support the challenge mean?
We're dealing with the pain.
What does support the challenge mean? Sorry, I just had to mute somebody. Lorraine, hun, you tried to come in YouTube and I misclicked. I mean, you tried to come into Zoom and I think I misclicked. So try again, hun. It was my mistake. It's nothing personal. Technology sucks. Okay, Donna. So see the pain, support the challenge.
Was it supposed to be supporting the challenge, Jill, of the pain?
I don't know.
Okay.
So the one that I was proposing was your story is important, your voice matters.
Yeah.
That's not bad.
No.
But see the pain, support. I just don't. I don't know what. Does anybody have any clue? What does support the challenge mean? Okay, Barbara says kicking for a cure.
Kicking for a cure.
It's cute. It's cute.
Hey, what's that first one that you said, Jill? What was yours? Wait a minute. What was yours again? That one.
Your story is important. Your voice matters.
Join the IC connection.
Join the IC connection. Getting there.
Be a part of the IC connection. Be a part of the IC connection. You know what? The reason why I said IC connection was because you're going to have a lot of Zoom meetings with other doctors and other people.
That's true.
And that's the connection. And that's a connection that we don't normally have in this COVID era.
Right.
So the connection is, you know what I'm saying? You know where I'm going with that, Jill?
So what about doing see the pain, make a connection, make the connection?
Make the connection. Making the connection to.
All right, come on. Now listen, you guys on Facebook, come on, give us feedback. What do you think? Any ideas on Facebook here?
Lisa, I see you over there.
So Elise says, see the pain.
I see you over there.
Okay, people need the meeting password. Hold on, let me, wait, did I just kick somebody? No, oh my God. I might have just kicked somebody accidentally.
No, you didn't. It's your birthday.
Oh, wait, okay. Oh, no, I'm fine. Oh my God. Woo! Wait, I think I'm okay. Linda? See, I got too many windows open on my computer right now. That is the problem. I need somebody to handle Zoom.
See?
I need somebody to handle. Okay, good. Okay, so Linda, I did not accidentally kick you. Woo! Okay, good. Okay, so Linda, I did not accidentally kick you. Okay. So hold on one sec real quick. Now I was going to look at something. Shoot. Okay.
I can't sing, Jill, but I'm going to sing, it's your birthday. It's your birthday. We can have a party. It's your birthday.
Thank you. Barb says, see the pain, connect to resources. Rhonda says, see the pain, make the connections. Elise says, see the pain, support the challenge. Oh, I was going to get the password. That was the thing. Okay, hold on. Sorry.
Okay.
See, I'm all excited here.
I know. You should be.
Okay, now I just got to, come on. Okay, now. Okay. The password is, and it won't let me copy the password. Okay, guys, here's the password. The number 8, a small J as in Jill, a small Y as in yellow, the number 6, a small H as in Harry, and a small U as in umbrella. 8JY 6HU. And I'm going to put the links again. All right. So Facebook, you just got the link again. YouTube. You have the link too. Tammy says, I was fine until I got my partial hysterectomy done at 44. Then came the bladder and the early menopause issues, which means that you have genitourinary syndrome of menopause, which I have too. The hysterectomy is fairly brutal. Okay, so, Christine, I see the pathway to healing.
Hey.
I see the pathway to healing.
I see the pathway to healing.
Okay, so here, hold on. I gotta mute somebody here real quick. All right. So you guys, throughout the rest of the meeting, can y'all just think about this slogan? And let's see. Let me just go through Facebook, see if there are any more. See the pain, make the connections. So Jill, hopefully you have the password now. Okay, guys. Again, the password is the number 8, JY 6, H is in Harry, U. Emma says, my GP keeps doing culture tests. My results are showing lots of epithelial cells, but no infection. I have a few white blood cells, not a lot. She said it's due to inflammation, not infection. Reading online, it says that epithelial cells show infection. That's not true, hun. Epithelial cells, your body's always shedding epithelial cells. In fact, in your vagina sheds all of your epithelial cells every 4 hours. So it could be superficial irritation. It could be lots of things, but I think the microgen test would be great. Okay, Julie, you've got the password now. Okay, guys, this is what I'm going to do. We're going to switch over to Zoom, and then we're going to come back to Facebook and YouTube. So let's go over to Zoom. And if you're having trouble getting in, you can send me an email, icnetwork@mac.com, and I can send you the invite that way too. Okay, so this is what I'm going to do. Let me just minimize other things on my computer so I can see everything. Woo, Betty. Okay, well, you know what, Donna, since your mic is on, let us start with you. Gosh, you make me smile every time I see you. I feel like you are my sister in IC, my sister in crime.
Exactly, sweetheart. And you know what? I'm doing very well. I know. I know. Hugs to you too. I usually don't come on because I'm doing pretty good. Hi, Lisa. Hi, Julie Roberts. Hi, Linda. Hi, Juliana. It's so good to see all of you. Hey, I'm a trainee. Trust me when I tell you, no big deal. But I just wanted to say happy birthday to you, Jill.
Thank you.
And that we appreciate you so much.
Thank you.
I do appreciate you, but I want to speak for our whole IC family, if you guys don't mind. We love you so much, and I hope that you're having a wonderful birthday. Even though you can't get out there and party, we're gonna have a party here. This is our party, being together. This is it, baby. So you know what? I'm not gonna take up any more time. I want everyone to get their questions in. It's just that I had to say, and I had to be here to say, I love you and happy birthday to you. And you look fan-freaking-tastic.
Oh, thank you. Thank you. You know, there are things about life that are so confusing, and we don't necessarily understand why it's happened and what has happened. And
yes.
And in my life, I have had a lot of health issues. It started in my 20s. They were all the related conditions to IC, along with the eventual IC. And here I'm letting somebody else into the meeting. But here's the one thing: despite the bad things that happen and the lost opportunities and the grief and stuff like that happens anytime you're in pain, anytime you're confused, anytime you're frustrated, anytime you lose friends because they don't understand why you can't go to the movies because you don't want to get up and pee every 15 minutes. The people in the IC community are stunningly wonderful. You guys have enriched my life. You have taught me what a real friend is. You have taught me the value of friendship. I wouldn't want to be anywhere else than right here. I really wouldn't, because you gave me hope. You gave me comfort. You gave me friendship when You know, listen, one of my best friends told me, Jill, obviously you love being in pain. You need to get help, and walked out of my life. I've seen her twice in 30 years. She was with me the day I got hurt because my bladder pain started with a chemical burn in a pool accident. And that night I woke up with agonizing pain from a chemical irritation, right? And so you lose people who were important to you. And then you realize, guess what? Maybe they weren't that important. Because it's the people who stick by you, it's the people who ask how you are. It is the people who call you and say, Jill, are you having a good day today? It is the people that you, and yes, it would be so great if we were like seriously in the same town and we could hang out. And if you had a problem, we could take you to the doctor and you could take me to the doctor. And, you know, we would do all of that. And Donna, hey, girl, I'm telling you right now, if I get burned this year, I could end up by you. I'm just warning you right now. Hey, you turned your mic off, hon. Let me turn your mic back on.
I said, you can stay here as long as you want. You just come on. All of you, you just come on. Well, hey, whether we have to sleep on the floor, who cares? You know what I'm saying? As long as we're together, you know?
Absolutely. Absolutely. And so, guys, listen.
Because, you know, Jill, pain and to all of you, you know how pain and health issues can age you.
Yeah.
And age you beyond your years. And I'm telling you, you've been going through it for a long time. And I wouldn't say that, especially you're Caucasian and you're a beautiful Caucasian sister, and you look fantastic. Age is nothing but a number, baby. That's all it is.
Thank you, girl. Thank you.
All of you. That's all it is. That's all it is. We're all beautiful. All of you are beautiful. We love you. And that's all I wanted to say. And I love every single one of you here. Jill, I love you. I'm going to stay on Zoom just to watch, but I'm good. Thank you so much.
Okay. All right. Thank you. All right. Well, let's go to, so you guys, you please don't take it personally. I'm just going to if I can see faces versus not faces versus who will it let me mute versus not unmute, because sometimes the computer is weird. And there was somebody who tried to get in and I disconnected her. And I'm so sorry, Lorraine, wherever you are. It wasn't Lorraine. It was the other one. Okay. Anyway, please try again. I'm sorry. Let's go to Linda. Linda.
Hi there.
Hey, girl. How are you today?
Well, I'm home because of the quarantine.
Yeah, ditto.
But this is the first time I've tried to go on the network, and that I'm on the Zoom meeting is amazing.
Isn't it fun?
Well, I've learned that's something new I've learned during quarantine is to be part of the Zoom meetings.
Yeah. Well,
this first time in I read the IC. One of them on Facebook, but I've never gone on this chat. I've had IC for 12 years.
Okay.
I'm 72. I was diagnosed, I think I got it going through a divorce. The stress, they can't tell you what causes it. But I've had success with hydrodistensions.
Okay.
I had 8 of them, except this last one I had in May. I didn't get the pain relief. In fact, I've had an awful flare this last week. I had a question for you. That I did start in acupuncture. And that doctor, I told him that my bladder was burning this week, like I had broken glass in my bladder.
Okay.
He had me take 1,000 milligrams of fish oil twice a day. This has only been since Tuesday. Of my 12 years, I've never heard of the fish oil. I've been using, aloe vera, the capsules, for 12 years.
Okay.
So
let me ask you a couple of questions here. Okay. So, and I apologize for asking about your age, but it is relevant to this discussion. How old were you when your symptoms began?
I think 60, because I'm 72 now.
Okay. You are not 72. No way.
My birthday was Wednesday.
Oh, there you go. Hey, another cancer patient. Woohoo! We are moon children, also known as cancers in the horoscope. So you were 60 when your symptoms began. Prior to that, had you had any history of bladder issues, any at all?
Well, only bladder infections, which I felt were being from being sexually active when I was married.
Okay, but how often did that happen?
Gosh, I can't remember. Maybe a couple times a year. It wasn't a lot of them.
Okay.
But when I was diagnosed, going through my divorce, I think she tried 3 times to treat me for a bladder infection, and it wasn't helping. She says, well, she sent me to a urologist to be tested for interstitial cystitis.
So usually the first thing we rule out in somebody whose symptoms start after menopause is estrogen atrophy. It's called the genitourinary syndrome of menopause. And so you need to write that down and read it and search it. Because
estrogen atrophy?
Well, they will call it vaginal atrophy or estrogen atrophy, but the correct scientific name is the genitourinary syndrome of menopause. Now, what a lot of people don't understand is that aging affects your urinary tract. Just like, the classic symptom is you get dry, right? As you get older, you get drier. But what a lot of people don't understand is that, yes, your vulva and your vagina are mucous membrane organs that get drier, but so is your urethra and so is your bladder. They are also mucus-driven or mucosal tissue. And they rely on a nice thick coating of mucus to protect them. Unfortunately, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus. And that mucus, again, protects your skin from any irritants that might be in your urine, as well as any bacteria that might be in your urine. As you age, your estrogen levels drop, your mucosal layer, your gag layer on your bladder wall gets thinner and drier, and it's the same with your urethra. And the urethra is kind of like the canary in the coal mine. The urethra is often the first part of the urinary tract to react to the loss of estrogen. And so you might feel urethral burning. You might feel a drop of urine stuck in your urethra, just constant irritation of that urethra that many people would associate with infection, which in actuality is just dryness. The classic symptom of dryness is burning on the outside while you're urinating. So if as you're releasing your urine and as it's crossing your vulva, if that urine feels hot, we call it urine burn. That speaks to the quality and health of your skin on your vulva, which usually speaks to estrogen atrophy. So there is a huge group of women whose symptoms of frequency, urgency, pressure, pain, and urethral discomfort begin as they're going through menopause and or after menopause. And it's not a disease, it's aging, it's just the loss of estrogen. And so in your 30s and 40s, you might have been able to enjoy a cup of coffee in the morning, a sweet tea in the afternoon, a cocktail at night, and then all of a sudden one day it hurts. And it hurts because you finally lost enough estrogen that your skin can't defend itself from the chemical irritation of the coffee or the tea or the cocktail. So if I were you, one of the first things I would do is I would really look at genitourinary syndrome of menopause, because the treatment, it's kind of a two-phase treatment. Number one, if you give that tissue estrogen, it will start producing mucus, which will improve your tissue's ability to defend itself. So topical estrogen therapy is very, very effective. And if you have urethral pain, what they do is they have you rub a little bit of estrogen cream directly into your urethra. Now, everybody's different. Some people might have concerns about cancer or a history of cancer where they might not be able to use estrogen, but I use topical estrogen. And if I don't, I'll tell you, if I don't use it for about 10 days, it gets very sensitive down there. Your skin can produce more mucus and moisture if it has estrogen. Oh, wait, here, hold on. Jill is raising her hand. Yes, Jill. Wait.
I had breast cancer, and it was an estrogen positive breast cancer. So I'm not able to take those things. Is there anything else that I can use that might help that dryness?
Well, so on the outside, you can use coconut oil. You could use V Magic. Here, let me go. Do you know what? Do you have V Magic?
No, I have the coconut oil. I use it on my face and.
Let me go get my V Magic. Hold on.
Okay. I'm always so afraid to use any new products because you never know what they're going to do. Someone's like, "Oh, try this." I'm like, I don't know. Yeah, my doctor, I have migraines really bad. And the other day she said, well, on looking at interstitial cystitis B2. Oh, nope, can't take that.
Here, let me just open up this one real quick. So this is my. All right. So this is a new thing of V Magic here. And here, hold on. Because you know what, hun? It's my birthday. I get to give stuff away. How would you?
It's my birthday. It's my
okay,
birthday
Jill. How would you like this very V Magic that I'm opening? I will send it to you as a gift. How does that sound?
That sounds awesome.
Okay.
Thank you.
So, but let me go get a glove. So I'm going to put gloves on and open it. Okay. Is that okay?
Yeah.
Okay. Hold on.
She is the most loving, generous person.
What? Yeah. You know what, guys? I say let's.
You're right, Kay. You're right.
Let's clean off my shelves here. It's my birthday. I get to give stuff away. I like that idea.
Yeah.
Okay. All right. So V Magic, and I'm going to keep it away from my mouth. I want it to obviously comes with a security thing. It's like it's like I don't want to touch it because I'm going to send it to you. This is as close to the consistency of your normal moisture down there than I've ever seen. It feels good, and it's made with extra virgin olive oil, avocado oil, and sea buckthorn oil, and a little bit of beeswax and a little bit of propolis. So this is very, very popular. And so
I would love to try that.
okay, so if you will email me your address, I'm going to send this to you as a birthday present. Okay.
All right. Awesome. Thank you.
Okay. And then who else had a birthday? Who just had a birthday?
Me.
All right, hon. We got to send you something too. Now, let's see. Genitourinary syndrome of menopause.
I thought that was for the same thing.
Yeah, same thing. I only have one here though.
Okay.
What I have, the other one I have, this is B Magic, which is made by the same company. It doesn't have the sea buckthorn oil, which is more calming, but
Do you order that online or is it from your website?
it's from our website. Okay, so here, hold on a sec. Now I got to make a lot of notes here because I don't want to screw this up. I tell you what, Linda, if you email me your snail mail address, I will send you a V Magic too. I'll have my warehouse do it. You know what? And also, Jill, I'm going to have them do it, and I will keep this one. That way you won't have one that's opened. How does that sound?
Sure, that would be great.
Okay. And
I put my address on the chat. Do you still want me to email you?
yes,
anyway?
absolutely.
Okay.
Okay, so since I'm going to keep this one for my demo, I'm going to open this up afterwards. Okay, and I want to give you guys a sense. Look at, can you see how slippery that is? It's not sticky at all. It's super, super. It's just, it's perfect for your skin down there. Okay. All right.
Does that stop the itching as well?
It could, yes, it could. Especially the sea buckthorn oil. Sea buckthorn is very calming and soothing. So I can't guarantee it for sure, but it's worth a shot. So as a birthday present, I will send it to you, and we will go from there. Okay, so I just have to make notes. You know, whenever my tradition of my birthdays is I always pay for everything for my family. So, okay. So anyway, Linda, getting back to you then. So genitourinary syndrome of menopause. Your issue here is that your symptoms began at the age of 60. That immediately points us to estrogen atrophy. And the more important question here is, have you responded to any therapies in the last 10 years? Because what you're saying is, and correct me if I'm wrong, didn't you just say that you've had a lot of hydrodistensions? Was that you?
Yeah, my first uro was doing instills, and those worked for a while. She had suggested the hydro, but because it was temporary and it had to be put under, I wasn't interested. But
Okay.
I moved to Oregon in 2016, and it took me a while to find a uro that would treat IC.
Okay.
I had to drive to Grants Pass, 30 miles from where I was, and he suggested a hydro, and I was in so much pain by that time. It had been 6 months that I had any treatment. It was wonderful. I couldn't believe it. I felt like when Forrest Gump lost the braces on his legs and was just running, I felt so free from pain when he did the hydro.
Right.
And he said they could only be done 3 or 4 months apart, which I did. And then when I moved back to California, I didn't do the last test because I said, oh, my California uro will do it. Well, I got back to California and she said it was old school and she wouldn't do it. It took me 6 months to get another uro. And he said that he only does the hydro, but he wouldn't do what the doctor in Oregon did was injections of Kenalog.
Yeah.
And he said he didn't do that part of his practice. But then on my second visit, he said he would do it. And so the 4 hydros that he's done with the Kenalog injection have been fabulous. You know, I almost look forward to the surgery because I'm pain-free for almost 4 months. But now the last one that I had, which would have been number 8, I believe, in May, I didn't even get 3 weeks pain relief. I've been like in a flare for the last month.
So I think that, you know, you're misunderstanding to a certain degree how and why it's helping you. Because ultimately, in the end, we always want to figure out the fundamental core problem. Your hydrodistension is doing symptom management. It's not fixing anything. And we have to try to figure out what's broken so that you don't need to undergo the hydrodistension in the first place, right? So the reason why a hydrodistension helps you is that when you stretch the bladder, you break the nerves. The nerves in the bladder wall are broken. Therefore, you don't feel the frequency urgency or the pain. The bladder has 2 fundamental nerve groups, alpha afferents, which control frequency urgency, and the C fiber, which controls pain management. So if you stretch the bladder, you break the nerve. And that's why after you're over your post-op recovery, you feel great. But it will always come back because nerves always grow back. And the problem is that more nerves grow back than you originally had. So every time you break them, you're running the risk of having more nerves and more nerves and more nerves. It could potentially be dysfunctional. So I understand why you're doing it because it makes you feel good, but we're not fixing the fundamental problem. And we have to figure out the fundamental problem here. And if the fundamental problem is just the loss of estrogen, then we can get that tissue to improve substantially with a little bit of estrogen. That's why I really think it's important that you read about the genitourinary syndrome of menopause and look at some of the other symptoms and go back to when you were 60, when these symptoms began, because in the end, hydrodistensions are expensive. Hydrodistensions are risky. You're being put under anesthesia and you're suffering potentially post-op complications from that. Where if something like a simple estrogen can use vaginally can give the bladder wall what it needs to grow a healthy tissue, you might not need that again, right?
Is that estrogen cream prescription I have to go to a primary or a gynecologist?
Right. Yeah. The quality and health of your skin is a critical issue here, especially that we women have to follow and we have to monitor. Our skin changes over time, and your urethra and your bladder are skin, for lack of a better term, that changes with estrogen. It's called your urothelium. Your dermis is the epithelium. Your bladder wall is your urothelium. It is going to be influenced by aging. And so, what the American Urology Association says is that if your symptoms are not improving over time, if you're getting worse over time, if you're not responding to typical bladder therapies, and hydrodistension is not a typical bladder therapy, the AUA says, take a step back, revisit the diagnosis. Let's make sure we know what we're treating here. Because we know that the bladder can be a secondary victim of other problems in the pelvis. You could have a muscle issue. If you're not walking normally, having bad feet can affect your pelvic floor, which can affect urinary frequency urgency. So we've got to rule other stuff out too. So I'm not saying no to the hydrodistension. It's not my place to say no. It's my place to say, okay, I get it. I understand why you're doing it. But let's take a step back and let's try to figure out why it's happening in the first place. And so go back to when you were 60, and was there any event that you associate with the onset of your symptoms? Did you fall?
The stress of the divorce is what I've always thought it was from.
Okay. So when you're under stress, you subconsciously tighten muscles. That is a stress response. So, and one of the first muscle groups that gets tightened is your pelvic floor. And if you happen to be somebody who, let's say you rode bikes when you were younger, or you were an ice skater, or you're a gymnast, or you had a lot of babies, or you were a victim of sexual abuse, or something that traumatized your pelvic floor, what we often see is a history of traumas. And they can be little traumas, but a lot of them. And with each trauma, you get more muscle dysfunction and more trigger points. And then finally, there's some sort of an event, which is the straw that breaks the camel's back, which triggers pain and discomfort. So most of the top tier urologists at the national level, what they would be doing is they would be checking your muscles at that first appointment. They would be asking about your symptoms. And then they would also be looking at the quality and health of your skin. Because if your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder.
Does from putting that cream in your genital area, does it gravitate towards
it does. It does. Yeah, it does. And so normally if it's your urethra that's screaming, they have you put a pea-sized drop on your finger and you just rub it into the entrance of your urethra. That's what I do. It works like a charm because it's my urethra that started screaming for me when I was about 53. And if I don't do it for about 10 days, the whole burning and irritation of my urethra comes right back. I can always tell when I need to do. I tend to be pretty passive aggressive about doing my pelvic floor work and my skin stuff. I should be doing it Monday, Wednesday, Friday. I like Monday, Thursday, Sunday. I'm not really regular about it, but I can always tell, and it plays a good role here. So, and then in the meantime, if you would like to talk more in detail about your symptoms, I'd love to talk with you on the phone. Feel free to give me a phone call next week. I'm going to be taking tomorrow off, although I'll probably be answering the phone a little bit. We should talk. It'd be interesting to go back 10 years ago and see if we can reconstruct any other event or trauma or anything like that. Okay.
Right.
But in the meantime, I'm giving you homework tonight. I want you to Google genitourinary syndrome of menopause. And I have a video on our website called the Estrogen Chat. And I would really like for you to watch that too. And then let's talk. Sound good?
Okay, I'll check that.
All right. All right, hon.
Thank you.
You are very, very welcome. And happy birthday.
Well, thank you.
All right, Lisa. Lisa. Oh, here, hold on a sec. I'm trying to unmute you. Lisa, I tried to send you a link this week from Facebook because, and I don't know if you got it or not. Did you see that Venus Williams was offering tennis coaching? She was offering a new tennis. See,
I got a link you sent, but it wasn't Venus. It was I can only think of Gloria Vanderbilt. What's her name? Davenport. It was Lindsay.
Oh no, you're right. It was Lindsay Davenport. I'm sorry. I get the Venus.
I responded to you because I met Lindsay Davenport when I went to Wimbledon. Yeah, she was really, really nice. But
nice.
I am going to follow up on that link.
Yeah, tell me what you. So Lisa and I are both tennis players, so we have that in common. All right.
Not that I'm playing any tennis right now,
well,
unfortunately.
Ditto.
I'm afraid by the time I'm able to start playing again, I'm going to be too old.
Well, no. Never.
My brother is 73, and he has started running again. He's a tennis player. He's really fit. But I live in Houston, and things are really bad here right now. And the neighborhood I live in is real close to downtown.
Ooh.
So I finally got over my fear of leaving the house because of the COVID. And then I went walking, and this man started following me. And so I could tell he was following me because every time I turned a corner, he was following me. And so I was near my girlfriend's house, and I slipped into her courtyard, and I texted her, and she was home, so she let me in. Not only do I have vaginal atrophy, I have vocal cord atrophy. Doesn't that suck?
Oh.
Anyway, so she let me in to her house, but I didn't lock the door, but I was standing by the door, and she went in the backyard to get her 90-pound pit bull because she was thinking that the dog would scare the guy away. And the guy tried to come into the house, and he opened the door, and I slammed the door on him. And so we called the police, and the police came, and this was a couple months ago. So the police, they couldn't find him, but he said, get yourself some mace and a siren. And so I got all those things, but I'm afraid to walk outside now. So, and the area where I live is not a good area. I mean, there's a lot of homeless people, and there's a place, I don't know if you have it every place in the country, but there's a Facebook page or whatever called Next Door.
Yes.
And they post on their stuff, and there have been a lot of posts lately about guys that have been exposing themselves as you walk by or jog by. And I think this whole thing has just made people a little cuckoo. I think people are staying inside, and I think people are taking more drugs and drinking more booze and getting crazy. So it's awful. But I wanted to say, I echo what Donna said. I wanted to say happy birthday.
Thank you.
And I echo what somebody else said, which is you look like you're 20, maximum 30 something.
Oh my God, thank you.
I also suggest that you replicate your hair and sell it on your website, because you would make some that you wouldn't know what to do with it. And I also, when I responded to that thing, I wanted to tell you, I watch CNN. I watch CNN all the time.
Yeah.
So you can tell where my politics lie. But they actually had an advertisement on CNN about Almiron.
Yeah.
And about the Almiron lawsuits.
Yeah.
Although they pronounced it Almiron.
Yes.
Said, if you have been taking Almiron and blah, blah, blah. But I thought, well, they're advertising on CNN now, so that's rather interesting.
Yeah.
And I also wanted to say to Linda, because we're about the same age, so I was having a lot of vaginal atrophy. And yeah, I sent you the book that my GYN had me because Jill, you say you can't take estrogen because of breast cancer, but the newer doctors don't believe that. And there's that book written called Estrogen Matters, basically debunks that whole, NIH study that says if you've had breast cancer, you shouldn't take estrogen. But it's just a new thing. But
I used to take it and it worked really well for me. But then after I had breast cancer, I stopped using it because I was afraid to use it. So I would love to figure out.
So read this book.
Let me go get it.
Estrogen
I'll be right
Matters, that you can get on. You can get it on Amazon, like everything else. When I pay my credit card, I go Amazon, Athleta, Kroger's, Amazon, because I don't like the house. I buy stuff on Amazon that I used to buy at the store now.
Yeah.
And just in the past 3 weeks, I started doing curbside pickup because my neighbor and my friends were doing all my grocery shopping for me. I mean, I'm being in my 70s, I'm, like at that age and with health issues. I mean, I'm just too afraid. And I know for friends in their 70s, they're out going to the gym, going to restaurants, going shopping, going to have their nails done, going to have their hair done. And I'm like, yeah, that's good. Yeah.
And no mask, Lisa?
No, they're wearing masks because pretty much now in Houston, well, what amazes me, I do leave the house to drive to pick up my medicine and stuff like that, or to go to my curbside grocery pickup. It amazes me how many people, when they're walking outside, don't have a mask on, whether they're walking their dog or whatever. And I know it's hot down here. It is hotter than hell down here. But I'm sorry, wear a mask.
Yeah.
Because there's too many people in my area. You can't maintain that distance.
That distance.
Yeah.
And now they're starting to say, especially if you're exercising and breathing hard.
Yeah.
So, but anyway.
Well,
But
there's something to say
with the estrogen thing, so my older doctor, not old as in age, but previous, he was a Euro guy.
Yep.
He prescribed Jesus, the cream. What's the name of the cream with the applicator thing? Everybody uses it.
Estrogen cream, Monistat.
No, it's estrogen cream, but it's
Premarin.
It's Premarin. It's the other one.
Anyway. Estrase.
Well, estrase, but estradiol.
Oh,
okay.
Yeah.
So, you have to reuse that same applicator for a frickin' month. And no matter how hot the water is, there's no way you can clean that applicator. It always disgusted me. I would take like Kleenex and try to roll it up and clean it out. And I felt rather disgusting. So I finally got in to see and Texas is Houston's a big city. I finally got in to see the only doctor in Houston that specializes in vulvodynia. Because I was really hurting with my vulvodynia.
I have it too, yeah.
And she said, forget the cream, take Vagifem. And she gave me a prescription for Vagifem. It's this teeny little tablet, and it comes with its own applicator that you dispose of after you use it. And she gave me a year's worth because I don't go back to see her for a year. And it has worked really great. And I was having to take gabapentin to help with the pain from the vulvodynia. And I'm able to start coming down now off my gabapentin. So, the Vagifem, it's worth looking into for anybody who's struggling with vaginal dryness and pain because of vulvodynia type issues. So, and like you said, Jill, I mean, since I started that, like I was having And this was like in the fall of 2018. So it's been almost 2 years. I had to hire somebody to come move in with me because I was so sick I couldn't shop or cook for myself. I was basically in the bed or on the couch like 24/7. And it took about a year, a little more than a year, before I was able to get up and start doing stuff for myself. But so it was slow, but between the gabapentin and the Vagifem, not only did the Vagifem help my vaginal area, but it helped my bladder as well.
Awesome.
Yeah.
Like you said, it does kind of soak in there. So
Yeah.
All
right.
Because Lisa, I'm sorry, Jill, I do the vaginal ring.
Mm-hmm.
I have the ring inserted, and that has helped. I can tell. I mean, we're women here, so I can say this. But you know how your vaginal area, it looks, I don't know, looser. It just doesn't have the firmness. And when I got the vaginal ring put in, because I have vulvodynia as well, everything firmed up. I went back. I've only had it for 6 months, and I went back, and my GYN was like, "Donna, you look great down there."
Yeah.
Not to say, she was just saying it is working. And me and my husband we've been able to be more intimate.
Yeah.
Because I've always been in so much pain.
Yeah.
That we haven't had the.
It causes.
We haven't been able to be together. I mean, together.
We got it. Yeah.
Of course, we've been able to be together as in snuggle and hug and that sort of thing, but not intercourse, if you will. And so since I've had the ring, it's been so much better, and the pain isn't there. I do gabapentin as well. And
I think I just personally, this is my personal opinion, because I've seen many doctors, and in Houston we have many doctors. Even though I just read that our mayor wants to shut the city down for 2 weeks again.
Yes.
We have a really good mayor. But Houston's hurting. Houston is hurting right now, really bad.
Yeah.
And our governor, he opened too fast, and he opened the bars, and of course, all these young people got out there. And anyway, but I hope he does shut the city down for 2 weeks. It won't affect me.
I think that it's sad that all the progress that we made is now here in California. We were doing pretty well.
You were.
And then I don't know if you heard
what happened.
No. So what happened is they hit a prison at the Chino, which is a prison in the Central Valley. And then some idiot transferred patients throughout the entire state to other prisons. And it went to other prisons. And so now I am about I'm about 45 miles from San Quentin. One of the girls in my support group, her husband is a prison guard at San Quentin. A third of the prisoners at San Quentin have it now, and the staff have it, and it is spreading throughout the community. It's just spreading throughout the community.
Why is that? Because the staff gets it, and then they get out into the community.
Yeah. Right. Yeah. And
I'm supposed to go back to work next month because I teach school.
No.
Now it's I'm not gonna go. I'm not going back. I've decided that if I have to use my savings this year so that I can stay home, I am not going back contributing. Kids are going to die. Teachers are going to die. In New York City, 100 of their staff died because they didn't shut down early enough.
Yeah.
Staff of the school?
Yeah.
100 staff where?
In New York City, staff, including teachers aides, the people that work at the school, the adults. 100 now have died in that area because they didn't shut down the school stuff.
Where are you, Jill?
I'm in Sacramento.
My brother teaches at Sac State. So
I graduated from Sac State.
Yeah. So, guys, listen, here's the reality. This is not a political issue at all. Politics are not involved in this discussion at all.
That's right.
This is about a viral infection that is highly contagious I was looking, there's I think it was Harvard who did this new map. I was looking at it last night. I'd love to try to find it and show it to you. It's everywhere now. It's everywhere. And what do they say? That if 80% of Americans wore masks every day, 93% of the transmission would stop.
Mm-hmm.
And so it's wearing a mask should be a sign of bravery and courage and respect.
Well,
right?
And it can be
Wash your hands.
a fashion
Prime Minister got up and said the
statement.
same exact thing. He said on his national television to all Canadians, and he made that exact point that you're making right now.
Right.
And it's like, why can't we do that? I don't understand.
It speaks to the poor education in the United States in the sense
Yes.
that understand the difference between a viral infection and a bacterial infection and the concept of exponential growth. This
Amen.
exponential growth. We hit the first million in 90 days. We hit the second million in 40 days. We hit the third million in 20 days. And we're at a very dire point right now where if we don't shut things down, we're going to see 250,000 dead by the election, if not sooner than that. Because
I'm glad I got out of Florida when I did.
Oh, good for
I remember
you.
when I first came on, I was in Florida, and I'm in Michigan now.
yeah.
I'm so
Yeah.
Mhm.
So, I mean, I'm sure that people in here, Sierra, the Zoom pin is 8JY6, H is in Harry, U, all lowercase. 8, the number 8, the letter J is in Jill, the number Y is in yellow, the letter 6. The number 6, the letter H is in Heidi, and the letter U. Okay, that's okay, guys. Just hold on. I got people on Facebook who want to talk. Let's run through the rest of this YouTube meeting, and then we'll come back to Facebook. But you know what? We have to take control of our daily. We have the ability to control our exposure. That is why I'm here, not doing a birthday party. As much as I would love to do that, I told my entire family, stay home. We'll do a Zoom meeting. We're going to do a Zoom meeting tonight. Yeah, my parents are here
That
too.
is your birthday party.
Yes, it
birthday
is.
Party. I'm so glad we're here with you.
Yeah.
Exactly.
I remember you saying that today was going to be your birthday, and I wrote it down on my calendar.
Yeah. Well, all right. So how are you, hon? How are you doing?
Oh,
how's your IC?
I've had challenges. I've had some challenges. I was off my feet April 30th for a month and a half because I cut my foot. And then when I got back here to Michigan, I tore a ligament in my other ankle, and I've been off my feet. But you know what? I'm alive.
Here, hold on a sec. What was that?
Just says your prescription is ready.
Okay. My dad took a phone call. My prescription is ready from my pharmacy. Not that you all needed to know that. Okay.
I'm glad you're back with us. So I've been really down, but I do my best. I do my best not to let this overwhelm me. Now that I said happy birthday, I want to say two things to everybody. My grandpa, my dad's dad, was married twice. The first didn't have kids, hired a nurse to take care of her. Before she died, she said, "You should marry this nurse." My grandpa was an ear, nose, and throat doctor in Detroit. He was 50 in 1925 when my dad was born. When he was younger, he worked in Detroit, the 1918, the 1919, and the 1920 flu pandemic outbreaks. You got me. A lot of people think, oh, that pandemic was not, no. And he told people to wear their masks, and it made a difference then. It makes a difference now. I know I'm preaching to the choir, but I used to work in blood banking. My dad taught me to wash my hands before and after I went in a public restroom.
Mm-hmm. Mm-hmm.
And, now is the time to teach your friends how to wash their hands right. This kind of stuff. I know I'm preaching to the choir, but I feel very passionate about this because my very grandfather got chronic fatigue from working his tuchus off in the pandemic and was never the same after that.
Right. Right. It's Yeah, like you said, we get it because I think people who have dealt with disability and chronic illness already get it anyway. We already understand what it's like to be sick for a long term. For a long term, we engage on a daily basis in behavior to protect ourselves. We would be the last to not wear a mask because we don't want to be sick anymore. Right?
Can I say one thing? Can I say
second
one thing?
Yeah.
So my girlfriends, we do them on Monday nights. And they're all around my age. They're all between like 65 and 70. And they're all like, oh my God, we had to stay home for 2 months. We couldn't go to the house. I can't stand it. And I thought, I didn't say, but I thought, I was home for over a year.
Yeah.
Unable to get out of bed or off the couch. Over a year.
Yeah. Yeah.
And you guys never came and visited me. You know, I mean, a few of them did a couple times. I was so sick and I did complain. And so they stopped coming. And they're complaining about 2 months. So we're used to this. I mean,
know.
I hate to say it, but
You know who?
we're accustomed to what this is like. So.
You know who did a fantastic tweet last night was the guy running for Senate in Arizona, who was the pilot. You know, he and his brother, his twin brother, went to the space station. What's his name?
Yes.
Scott. What's his name? Anyway, so they were both twins. They were both in the Air Force. They were both for NASA. They were both astronauts.
And his wife got shot.
And his wife got shot. Gabby Giffords. And what's Scott? Anyway, he's running for Senate, right? I've already voted. I've already donated to his campaign. So he did this hysterical tweet yesterday where he's flying a jet. He's wearing a helmet, his full mask, his oxygen mask, and he says, hey, listen, if I can wear this mask and fly a supersonic fighter and I'm fully functional doing that, surely you can wear a cotton mask. It was great. Okay, we got to keep going. I got people that are anxious here on Facebook too. Let us move along. But anyway, if you can follow him, Scott, something, just Google running for Senate. Fantastic. He's going to be a great senator, I think. All right, Julie Ann, my dear. Julie Ann is laying on her bed right now. Girl, you look like you're not feeling very good. What is going on?
No, I've
honey.
gotten up about 4 or 5 times during this meeting to use the bathroom.
Dang it. Are you better or worse today than you were during our last meeting? Because you were struggling last meeting too.
I'm feeling worse. I went to the urologist this week. I did speak to my mom after we had our discussion last weekend, and she told me that I did take a stumble down the stairs a couple of times when I was growing up.
Oh, okay. So, so now we have some potentially triggering, damaging events for your pelvis. And the odds are, as a kid who doesn't fall on their tailbone at least once, the odds are if you fell down the stairs, you probably took some pretty significant pelvic traumas. Do you, does muscle relaxation help? Does heat help? What makes you feel better?
Hot baths and a heating pad helps, but I can tell you that when I turn off the hot water, when I take off the heating pad, the pain comes back within 5 to 10 minutes.
But does the pain go away when you use the hot?
It goes away when I use the heating pad, and then when I take it off, it comes back.
Okay, and you have to refresh my memory here. Can you describe where your pain is located? And for everybody else who's watching.
Mostly in my bladder. And when I spoke to my urologist the other day, I told him that it's like a serrated knife. That out and stabbing me again.
And what did he say?
He said that he wants to do another hydrodistension. This will be my 5th one since I was diagnosed.
And what was the status of your pelvic floor?
I scheduled an appointment to do a pelvic floor for next week.
Okay. So obviously that's the missing link here. So when you go for that pelvic floor examination, you're going for the first time to your pelvic. Remember, the purpose of that appointment is to study your pelvis. They're going to look for tension patterns. You're going to start with your clothes on. They're going to watch you walk down the hallway. At least they should be watching how you walk down the hallway. See how you're walking. They should measure the length than the other. They're going to look for tension patterns. They're going to look at your glutes. They're going to look at your core. They're going to look at your legs. They're going to look at anything that has the potential of influencing your pelvic floor, right? And then you're gonna take off your below the waist. Obviously, they'll be out of the room, and that's when they're going to do a very gentle pelvic floor examination. Okay. And in that examination, you have to remember you've got 3 layers of muscle. So each knuckle is an equivalent of, ironically, if you were to stick your finger up your vagina, that's a really good representation of where the muscles are. You got deep muscles, middle muscles, and shallow muscles. So what they're going to do is very gently palpate muscles. They'll start shallow, and then they'll go a little bit deeper, and then a little bit deeper, and they'll just be touching, right? And if they can touch it and reproduce your pain, that is a hallelujah moment. It's like, yeah, babe, you found it. What are you touching right now? What are you touching right now? And that's what we want. That's what we want. And so I don't want you to walk into that appointment upset. I don't want you to walk into that appointment stressed out. This person is your ally. You are getting them to study your body. And I don't want you to walk in and just say, I don't know why I'm here. I have bladder stuff, et cetera, et cetera. I want you to say that we are trying to unravel this mystery of why I have what I have. I feel like somebody's stabbing with me with a knife. But what's interesting about it is when I use heat, the pain goes away. But as soon as I stop the heat, the pain goes back. The other question would be, how would you do with a muscle relaxant? Does a muscle relaxant make your pain go away? And then when the muscle relaxant wears off, does the pain come back? That would be that would be interesting to talk with your doctor about after your exam, because if your exam finds that your muscles are tight, then that's the hallelujah moment. We know what we're working with. We know what we're working with. And I think in the end, you're going to be surprised. I think you're going to be very, very surprised. So would you call me after your appointment and let me know what they found?
Yes, definitely.
I'm very encouraged for you. I think that's going to explain a lot. What's going to be challenging, and just to be fully honest, is that when you watch the examination, shouldn't be traumatic, right? I wouldn't, especially if they're gentle. You got to be vocal. You're a part of this. You got to tell her, okay, that's a little uncomfortable. Okay, that's weird. That makes me feel like I have to have a bowel movement, whatever. If they're pushing on your levator ani muscles, for example, you're going to feel that same pressure you feel if you're going to have a bowel movement. You're not going to have a bowel movement. It just means that they're touching the muscles. But just really communicate with her and let her know what you're feeling, and ask questions and be your team. You are as much of a participant as she is. If you're not, you're the most important participant, because you're the one that's giving her the signals. After that, if she finds that you've got muscle tension, listen, I want you to be prepared to get right home, grab your heating pad, stick it on your belly, lay in your recliner, and just chill for a couple hours. Just chill for a couple of hours. And then.
No, I have a question for you.
Yeah.
Every year when I go to my OBGYN to do my yearly checkup, I'm always in pain when they do it. Is that normal for me to be in pain?
No, hon, you've got vaginismus. You've got vaginismus. Donna's husband's waving. Hey.
Yeah, that's what I wanted you to see. Say happy birthday to Jill.
Happy birthday, Jill.
Thank you very much. Thank you very, very much. I appreciate that.
I wanted you to see him, guys. He's a really good guy.
He looks like it. He looks like it. Okay, so getting back to vaginismus. That, honey, vaginismus is not normal. It is not normal. It means that, I mean, that right there is a de facto diagnosis of tight pelvic floor muscles. If you have always had pain when you go for your pelvic, that tells us that your pelvic floor muscles have not been healthy for a very, very long time. That points right back to something that happened in your childhood. Okay?
Okay.
So the good news here, you know, and this is something that you can really take to heart, is that muscles respond to muscle therapy beautifully. But the problem is that this is not something that's going to get fixed overnight. You've had tight pelvic floor muscles for a long period of time. And it probably is going to go right back to whatever happened in your childhood. And this is about learning new muscle memory. So you know, the good news here is that pelvic floor physical therapy works, but it takes effort and time. Your muscles are screwed up, and they've been screwed up for decades, right? A decade. How old are you?
I'm going to be 28 on the 25th.
Okay. So for at least a decade, your muscles have been messed up. And so, and then of course, now you remember, now girl, have you gotten this book yet?
No, I haven't.
For you, in honor of my birthday, I'm going to send you this book. Okay? I want you to email me right now. Email me your info, and I got to write this down. You need this book. So I'm writing down your name, Julianne.
Can you give me your email address?
ICNetwork at Mac, at Macintosh computer. ICNetwork at Mac.com. You are getting this book. Okay?
That's breakthrough pain, pelvic floor.
Breaking through chronic pelvic pain. All right. So Linda and Jill are getting V-Magic. Julianne is getting Breaking Through Chronic Pain, and I'm going to give more away. I am.
Jill, when you told her to take a muscle relaxant, are you talking about an oral muscle relaxant?
Yeah. Well, you can.
Which one, like what?
Baclofen. Baclofen is non-sedating, so baclofen is a preferred choice during the day. Flexeril, also known as cyclobenzaprine, is also a skeletal muscle relaxant. It does have a sedating quality to it, and so Flexeril. When I take Flexeril, it would be I use just a quarter of a pill at night before I go to bed. Jennifer on Facebook says, "What are the 5 kinds of IC?" Jennifer, if you can hold on 5 or 10 minutes, we will come back to that. We're just finishing up our Zoom meeting, and then we will come back to Facebook and YouTube. Okay. We're simulcasting in 3 places right now. We're simulcasting on Facebook, on YouTube, and on Zoom. So we're doing the Zoom portion of the meeting right now. Okay, so Julianne, you, my dear, are going to get this book from me. I think I had 4 copies left. I'm not sure if they sold out, but they're sending us another 20 copies. So I will make sure you get one.
Okay.
And as you read it, I want you to don't jump around. Yeah, you're going to jump to the IC chapter. You're going to jump to the vulvodynia chapter. It's okay. Read that for 10 minutes. Get right back. You got to start at the beginning. You got to learn everything you can about your muscles, because everything you're saying is pointing to muscles. And we have to try to understand the original injury you had and why you continue to have vaginismus. And you need to tell the physical therapist when you see her that it is always hurt. It is always hurt. Now here's the deal. If your muscles are super, super tight, she might not be able to do much vaginal work at first. That's okay. It's totally okay. We're going to start. They start from the outside. They'll kind of work from the outside in. So we definitely want to. You just. Listen, you just talk to her. You just communicate with her. You just let her know how you're feeling. But the second thing I really want you to think about, and this is something that he talks about in this book, is why do people stay in tension? Because physical therapy, a hand on the muscle can relax a muscle. We know that. We know that. What baffled Dr. Weiss, who wrote this book, is why do patients come back a month later with their muscles still tight with trigger points in exactly the same location? Why? And he, it's so funny because I've been saying this for a year. For those of you who've been here, I always say, look beyond the bladder, right? I mean, I've said that for a long time. If your muscles are always tight, let's look beyond the bladder. He introduces an important concept called a mechanical injury, a mechanical dysfunction. If your muscles are always tight, there's something in your body tweaking that area. So could you have scoliosis like I do? Could you have an SI dysfunction? Could you have a hip issue? Could you have a knee issue? And in his book, he talks specifically about the feet, that if you don't walk normally, that will be deflected all the way up through the muscles in your legs and the fascia, all the way up to your knees, to your hips, and into your pelvic floor. And what he found is that 90% of his patients who had tight dysfunctional muscles had foot problems. And he called it unraveling the layers, unraveling the layers. He could get the pelvic floor relaxed. He could deal with nerves. But the last piece of the puzzle was, why were the muscles in this specific location tight? And it went down to how they were walking. That if you've got one leg longer than the other, you've got one arch that's flattening and one arch that's arching. And it just messes with it.
Because I do have one leg shorter than the other.
So that's something you've got to talk with the pelvic floor physical therapist about. And you might even need to go talk to a podiatrist about. And let's see if we can get you walking correctly so that we are reducing stress on your pelvic floor. Okay? Okay, hon. So listen, I want you, so I will get this book out to you when I can. I think I have a couple copies left. If not, we have to wait for my next order, which I think they said would arrive on the 20th, but I promise you I'm going to get you that book. Okay?
And can I find your phone number on the IT network?
It's on the top of every page. It's on our Facebook page. It's an 800 number. You can't miss it. Okay?
Okay.
Okay, hon. Nice talking with you. All right. So who have we missed on Zoom? I know a couple of people have left. Elise, did we do you, Elise? I don't remember. Elise, are you there? Elise. Nope. Elise is not there. Elise has left the building. All right. I tell you what. So I'm going to leave the Zoom meeting up for the short term, but let's go back to Facebook and YouTube here. All right. So let me just move stuff around here. Becky had her birthday, 37, had her birthday last month. Becky says, I never had a hysterectomy, but I had early menopause. You betcha. She says it sucks. It does. I want to go to Facebook here. We've got a lady named Sally, and Sally is from the United Kingdom. And she says that, and Sally, let me just scroll back here real quick. And then Jennifer, I will get to your question. Sierra, I will get to your question, but let's do Jeannie. Thank you for your birthday wish. Sally says heat helps her. I agree in your bladder. That's almost just like me. Oh, so Sally says, I'm rather worried that I can't get off antibiotics when I do get a flare. I have never in my life experienced pain like the last year. I have a smear test. I had a smear test, got cystitis. It never went away. The pain was indescribable. Never had anything like it. Nothing took it off. Went into the hospital in the end. You drank too much water. Went to Spain in the end. My wonderful doctor diagnosed me there, told me the pain was nerve pain, prescribed amitriptyline. It was like a miracle. So, Sally, I want to try, hold on. I'm just kind of scrolling back through your messages here. I want to make sure I understand this. You were diagnosed in Spain. He was amazing. They had no idea in the UK. The minute you try to come off antibiotics, your IC comes back. It's so weird. So let's do this. And this is also going to answer somebody else's question. Jennifer, this is going to answer Jennifer's question too. So hold on a sec. We need to, hold on. I got to find the right slide here. Answer Jennifer's question too. Somebody's got their mic open. Hold on a sec. All right. So Sally, and Jennifer. Let's talk about this for a moment. So if you spend any time with IC patients, you know, and you can see there's a lot of diversity in this patient population. There's no doubt about that. For some people, IC begins in childhood. For others, after menopause. For some people, IC begins after a baby, while for others, IC begins after chemotherapy or a terrible diet. IC is a grab bag diagnosis. It is something, it is what a lot of doctors will say you have IC, but they really don't get it. They really don't understand. You could have fibroid tumors pressing on your bladder. You could have endometriosis on your bladder. You could have pelvic congestion syndrome. You could have Tarlov cysts. The bladder is often a secondary victim of another issue. So when you are in the process of getting diagnosed, you are in the process of solving a mystery, the mystery of your pelvic pain. You are an anatomical mystery to be solved. And yes, you're having bladder symptoms, but that doesn't necessarily mean that it's your bladder that is the primary cause. Your bladder is going to scream in many other circumstances too. So what doctors are doing now around the world, there's kind of a contest right now. It's a competition among clinicians and researchers around the world to define the subtypes, the variants of IC, because we know that a one treatment fits all approach does not work. We know that. Elmoron does not work for most of the people who try it. And now, of course, we know it's associated with eye damage. So there is a very clear and consistent effort to try to define these variants. We want to give you a correct therapy. We want to give you a correct treatment pathway for your unique presentation of IC. So if you were in Europe, Europe has 12 variations of IC, and they do their subtyping or phenotyping based upon your symptoms and what your bladder looks like, as well as pathology results. Now, in the United States, we approach it a very, very different way. In Canada, they use a system called U-Point. And in the U-Point system, they evaluate every patient with six different criteria. The health of your bladder wall, your bladder symptoms, the presence of infection, the presence of any other neurologically driven symptoms or conditions, the presence of your pelvic floor, as well as the presence of any catastrophizing. And using that system, you get to create a customized treatment protocol. So if you were in Canada, your IC diagnosis would be based upon that system. In the United States, we don't have a nationally agreed upon subtyping system, and there's keen discussion and disagreement about subtyping at the upper top tier research level. I will tell you, though, that I use a system that was proposed by Dr. Christopher Payne several years ago. Chris Payne was the IC research director at Stanford University for 25 years. He's chaired National Institutes of Health meetings. And he wrote a paper a couple of years ago where he said he thinks that there are 5 core variants of IC with subvariants in some of those categories. And I think he nailed it. It's what I use now when I work with patients. But when he introduced his system, he did it in a very provocative way, because he said, we should be treating IC patients like cancer patients. And of course, in my brain, I'm going, oh my God, don't mention cancer and scare people. There's no relationship between IC and cancer. And when you read the article, that's not what he means. What he says is that when you're diagnosed with cancer, they don't just say you have cancer and walk away. They give you a very specific diagnosis. You have cancer of the left breast, estrogen dependent, type 1, 2, 3. Or for me, complex endometrial hyperplasia with atypia and a vague architectural complex. I double dare you to say that 5 times fast. The more specific the diagnosis, the more clear the treatment options are. So when I was diagnosed with my diagnosis, we knew exactly what my treatment options were, which was basically hysterectomy because I had early uterine cancer. And he argues that when you're diagnosed with IC, you don't know what to do next. Your doctor doesn't know what to do next. You have, other than throw Elmeron at you or maybe DMSO at you, you don't have a clear intuitive treatment pathway. But if you do a more specific diagnosis, you will have a more clear treatment option and pathway, because we don't want you to take Elmeron for 20 freaking years, lose your eyesight, only to discover after the fact that your problem really was never your bladder wall in the first place. And believe me, that's happening. That has happened. And so in his system, he proposes 5 core variants. So let's go over these really quickly. And then we're going to come back to Sally, because I'm going to bring you into this. And Jennifer, you're getting this. And Sierra, we're going to talk about this too. Okay. IC subtype 1 in his system is Hunner's lesions. Everybody in the world agrees. Everybody in the world agrees that Hunner's lesions represent its own unique subset. Hunner's lesions look different and they have different biopsy results. So hold on a sec. Where's my pictures? Where are my pictures? Now they were right here. Here they are. Okay. So look at this. These are Hunner's lesions. Big, red, bloody spots. They are known to bleed profusely, waterfall effect. They are known to have a center area with arms radiating. We call that a stellate appearance. This is severe. When you biopsy the center of these lesions, you find massive inflammation. There is a war happening. There is a war happening in the middle of a lesion that is not happening in everybody else. This is only lesions. So there are 2 theories about, there's multiple theories about lesions, but the 2 most common ones is, number 1, that a lesion is a viral infection. Because we have research in Europe that has now isolated several viruses in the urine of patients only with lesions. And we just had our first U.S. National Institutes of Health MAP Research Network study, which also found the same virus, polyoma BK, and also they found a second virus, polyoma JC, in the urine of some IC patients, suggesting that some patients may have a chronic viral infection. Now, listen, when you think bladder infection, you're thinking bacteria. You're thinking, antibiotics would work. Well, guess what? Antibiotics don't work with a virus, just like antibiotics don't work with COVID. So, theory number 1 is that your bladder has a viral infection. And we already know that viruses can affect the bladder wall, because we already know that polyoma BK can cause hemorrhagic cystitis in patients who are immune compromised. So isn't that mind-blowing that some patients could have a viral infection, which then brings in the use of antiviral medications? Now we know why these patients, Hunner's lesion patients, didn't respond to Elmeron, right? If this is a viral infection, that's why. But the second theory is that this also could be an extremely irritated, damaged nerve, because nerves that are damaged release substances which damage tissue, called substance P. And so those are the two theories. Now, interestingly, lesions require lesion-specific therapy. They can be cauterized or fulgurated or lasered, or you can inject right into the center of the lesion a steroid solution, triamcinolone. And what does that do? That reduces the inflammation. But we do have a treatment. We know hyperbaric oxygen therapy can help. And we do have a treatment that actually healed Hunter's lesions in 2 weeks. It's called Liris, L-I-R-I-S, also known as a lidocaine pretzel. It's a medical device filled with lidocaine that they put into your bladder. And for 24 hours a day, for 2 weeks, it numbs the nerves in your bladder. It was originally created for pain. And it was created at MIT as a new way of delivering drugs to the bladder over a long period of time. They were stunned in the very first research study, as well as almost every study they did, that it made Hunter's lesions disappear. Why would lidocaine, numbing a nerve, make a lesion go away? Because it's silencing the nerve. So it could either be something living on the nerve, like a virus, because viruses live on nerves, or the nerve itself is the problem. Okay, so obviously, Hunter's lesions require very clear, specific therapy. And unfortunately, we cannot get Liris right now. Allergan, the company that currently owns it, has shelved it. All right, that's IC subtype 1. IC subtype 2, using the pain system, is this. Now remember, this is very different from this, right? Big bloody wounds, little tiny wounds. The bladder, like any other part of the body, can be injured. And so IC subtype 2 is bladder wall driven. It means that there's something funky with your bladder wall. And we know your bladder wall is driving your symptoms. If you have pain as your bladder fills with urine, that is relieved by urination. So the fuller you get, the worse you feel. But as soon as you pee, there's a sense of relief, right? That tells us your bladder wall specifically is driving your symptoms. So in this category, we're really looking at 3 fundamental things. The first thing we're looking at is chemical injury. So if you're addicted to diet soda and you're drinking diet soda every day, if you're using ketamine every day, if you're taking chemo every day, your bladder is going to be hurt from that. And these are pictures of a hurt bladder. This is kind of the equivalent of, and now remember, this is my interpretation of this. I'm sure that other doctors and researchers would have a different perspective on it, but these petechial hemorrhages and glomerations, I kind of compare to a skin knee. You know how if you fall and skin your knee, you get a lot of little tiny wounds? That's kind of what this looks like to a certain extent. I mean, clearly the bladder wall is very, very irritated. So it could either be a chemical injury, an insult from the outside that's come in and provoking your bladder. So this is where lifestyle kicks you in the butt. If you've been drinking coffee all day, every day for 20 years and not drinking water, that's not normal. That's going to take a toll on your urinary tract and your bladder health. If you've gone through chemotherapy, the chemicals of the chemo have the potential of doing that. If you have a terrible diet, that has the potential of doing that too. So our therapeutic priority for this group of patients is to stop irritating the bladder and give the bladder an opportunity to heal, because healing is always happening. Healing is always happening. That never turns off. Your bladder is trying to fix whatever the hell is happening to you right now. But the challenge is you might be getting in the way, because if you're still drinking a cup of coffee every day, you're killing the next generation of cells. Imagine an extra large pizza and imagine a little tiny green pea underneath that pizza. That extra large pizza is a urothelial cell. The bladder has the largest single cells in the human body. They're giant, giant cells. And when that cell is damaged and is sloughed off, there's this little tiny green pea underneath, the little tiny stem cell that is the next generation of cells. It takes a minimum of 2 weeks for that cell to grow and adapt and fill in that spot that was left by the urothelial cell. While that is growing, it is exquisitely vulnerable to acid. And this was presented by, again, I think by Dr. Anthony Schaefer at a National Institutes of Health IC meeting probably 15, 16, 17 years ago. And what he said is that while that cell is growing and adapting and changing to fill in that spot, it is exquisitely vulnerable to acid. So literally, 1 cup of coffee a day will destroy it. 1 soda a day will destroy it. So every time you have that cup of coffee, you set yourself 2 weeks worth of healing. It is impossible for your tissue to repair itself. It cannot repair itself and heal if you're bathing it in acid every day. Let me tell you a story. I had a lady call me from New York. She had terrible symptoms. I spent a long time with her on the phone talking about diet and diet modification. And I gave it to her. And she was very memorable. I will never forget her voice. It's a very kind of shrill, hysterical voice. But I talked her down for an hour, spent a lot of time with her, sent her to the top doctor, one of the top doctors in the United States who lived 20 minutes away from her. She calls me 5 years later and she's hysterical again. She's hysterical. Jill, nothing works. Nothing works. I've done everything. Nobody's helping me. I'm in agony. I don't know what to do next. And it's like, okay, hold on. Let's go back. Go over her symptoms. She has a pain as her bladder fills with urine. It's like really, really bad. It's like, okay, hun. So I got to tell you, it really sounds like your bladder wall. And it really sounds like your diet. Are you following the IC diet? She goes, yes, absolutely. I'm doing everything. Her husband was on the phone. He goes, are you kidding me? She drinks a pot of coffee in the morning. She follows it with a 6-pack of Diet Coke in the afternoon. She's never followed the diet. And she lost it on the phone. Hysterical. Oh, she was screaming at him. She was screaming at me. She was going, that's right. Take away everything I love. I have nothing to live for if I can't have my coffee and my soda. Bam, 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 bam. Hysterical. And I'm listening to her and I'm going, honey, how much? I said, well, the first thing I said is, now listen, I told you about the diet. Did you follow it? Didn't you believe me? She goes, no, I didn't believe you. So you went and saw Rob Moldwin, top doctors in the country. Did he tell you about the diet? She goes, yeah. Did you believe him? She goes, no. I said, then you went to somebody else. Did they tell you about the diet? She goes, yeah. Did you believe them? No, never believed them. And I said, how much money have you put into therapy? How much money? How much money have you spent for your treatments right now? $30,000. I went, do you realize you have sabotaged every single one of your treatments? They never had a chance to help you. Never. And she goes, what? I went, listen, there's no treatment that's going to counteract the damage of a pot of coffee in the morning, followed by a 6-pack soda. You never gave any of them an opportunity to work because you did not believe us and because you are an addict, severely addicted to caffeine. And she's wailing on the phone. I didn't know. And it's like, honey, that's not good enough anymore. I spent an hour with you. You have spent thousands of dollars. Everybody has told you about the diet and you have blown them off. And she got very, very quiet. And it's like, you got to try. What do you have to lose? For God's sake, try. And she's like, and then I explained the pepperoni pizza and I explained the research and said, you prevented your bladder from healing, period. End of story. So, she's very chastened. It's very rare that I ever yell. You guys, listen, y'all talk to me on the phone all the time. It's extremely rare that I ever get upset with anybody. I was pissed at her and for her husband. He was angry too, right? Okay. So we hang up the phone. She calls me back 3 months later. Oh my God. What? I'm better. Really? I have been on the diet for 2 months. My pain is in half. I can sleep through the night. And it's like, there you go. She goes, thank you so much. Thank you so much for telling me. Because she didn't understand the physiological toll that acids play on the bladder wall. It is not impervious. It was not designed for today's modern life. It was designed for life 100,000 years ago when the only acid they had was when fruit was unripe once a year. So be realistic here. Your diet matters. And it especially matters as you get older, because the second thing we have to consider with the health of the bladder wall is aging. Aging. Because your bladder relies on estrogen to help produce mucus. And when you're young, you have lots of estrogen, you have lots of mucus, and you can get away with a pot of coffee in the morning, maybe, until it hurts you. But guess what? As you get older and you lose estrogen, you lose mucus. And your bladder's ability to defend itself is compromised. It changes. It gets worse as you get older. And here, that was somebody on Zoom. Hold on a sec. I've got my Zoom hidden. You guys just hold it on Zoom for a moment. Okay, let me just get through this, okay? So the genitourinary syndrome of menopause is real. I work with patients every day who just didn't know, and their doctor has given them estrogen. They've said they're dry, and they don't use it because nobody explained why. Nobody explained why. So it is important that you understand that aging affects the urinary tract. I have a video on our website. Go to icnetwork.org, or you're on our YouTube channel. It's called The Estrogen Chat. Watch it. Read it. It's real. The third thing that we're going to consider in bladder wall-driven symptoms is the role of chronic infection. So this gets to Sarah. Sarah says, whenever I go off my antibiotics, it gets worse. So there is a small subgroup of patients who could have chronic infection. There's no doubt about that. Not everybody. We are not making blanket statements that everybody has chronic infection. Because the first thing we have to understand is that there are two different types of infections possible. Yes, you could have a chronic bacterial infection, especially if you are of a certain age. But what do we know now? Is that the National Institutes of Health MAP Research Network is finding a different kind of infection in some IC patients, a candida infection, a fungal infection in your bladder. And we knew that 5 years ago with patients and flares. In their first study, they found that patients having flares had more fungus in their urine, candida in their urine. And then we've had multiple studies continuing to validate the presence of fungal infections in IC patients. The most recent one identified 13 different species of pathogenic fungus in the urine of some IC patients. And what they found is that the more species you had, the worse the pain, the worse the flare. So yes, there is a vibrant group of people online who say everybody have chronic bacterial infection. The science doesn't support that. The science is finding viral infection and fungal infection. So how do you know if you have a fungal infection? Number one, do you flare when you eat sugar or carbs? Because fungus feeds on sugar or carbs. So there's a small group of people out there. It's like, why the hell am I flaring and I eat a cookie, a sugar cookie? Because a fungus will feed on that. Now, remember, I'm not saying everybody has it. I'm just saying a small group of people has it, but it's possible. So how can you figure out if you have a fungal infection? Again, next generation urine testing. You can go to bladderhealth.org. Even if you're in England, they work with England, bladderhealth.org. They will check your urine for good bacteria, bad bacteria, and fungus. The proof is in the pudding. You know, at some point in time, you have to stop guessing. And Sarah, in your case, or Sally, in your case, here's the deal. You feel better on an antibiotic. I get that. Now let's figure out why. Some antibiotics have an anti-inflammatory effect. So you might just be feeling better because it's reducing inflammation. But you could have a chronic infection. I am open to that. But the proof is in the pudding. No guessing. Let's get a next generation DNA test and see what it happens. See what it finds. Because it would be a real tragedy for you to take antibiotics and risk developing a lot of other conditions like C. diff or chronic fungal infections because you're using antibiotics inappropriately. If there's one group of patients completely overexposed to antibiotics, it is in fact the IC patient. We have all taken antibiotics excessively. They have been prescribed to us excessively. I remember as a kid swallowing 16 pills at one time in my doctor's office, and so there you go. There you go. So for IC subtype 2, bladder wall driven, chemical injury, estrogen atrophy, chronic infection, and there are probably more. Hormones would play a role here too. There could be another younger hormonal condition, but there's more. Let's go to IC subtype 3, pelvic floor driven. This is the largest subtype. These are the patients whose symptoms began after a pelvic injury, and there's a hell of a lot of you out there. A car accident, a fall, a history of athletics. I was working with a mother whose son, who was in his early 20s, had IC appear. His son was a football player. And nobody was helping him. He had to drop out of college. He was at home in bed, very despondent, didn't make any sense. She calls me. I talk to her. I say, hey, can I talk to him? He's like, I don't know. Well, he called me a week later. I talked to him. It's like, all right, dude, let's talk about it. Go back in time. Did anything happen right before this? He goes, yeah, absolutely. I fell off the ski lift. My symptoms started the next day. His football team went skiing. He fell off the damn ski lift. His symptoms started immediately afterwards, within 24 hours, because he had a severe pelvic floor injury. And when your pelvic floor muscles, which of course go from left to right, front to back, low to high, and your bladder sitting right there in the middle, if your pelvic floor muscles go this, your bladder is not going to get the oxygen it needs and nutrition it needs to be healthy, and it is going to trigger all the symptoms you associate with your bladder: frequency, urgency, pressure, pain. And this is where this book is the bomb. This book is amazing. So if you have pain after urination rather than before urination, that points us to your muscles. If you have pain to the left or to the right rather than in the middle, that points us to the muscles. If you cannot start your urine stream right away, if you hesitate 5, 10, 15, 20, 30 seconds, 1 minute, 2 minutes before you can relax enough to empty your bladder, that points us to your muscles. If you as a woman have always dreaded having your pelvic exam because it always hurts, that points us to the muscles. And here's what we know for this group of patients. Bladder therapies might make you a little tiny bit better, but they're not going to solve the problem, because the problem is tight muscles restricting blood flow to the bladder and restricting nutrition and damaging nerves. So that's IC subtype 3. Whoops. IC subtype 4, using the pain system, is pudendal neuralgia. So think about it this way. IC subtype 1, potentially viral infection. IC subtype 2, bladder wall driven. IC subtype 3, pelvic floor driven. IC subtype 4, nerve driven, pudendal neuralgia. So these are the patients whose symptoms are very positional. You're fine when you stand, but when you sit down, it hurts. You can't sit for long periods of time. When you bend over, it hurts. Or when you squat down, it hurts. Or you have sciatica pain shooting down your legs, an electrical sensation like you're being shocked, right? Donna's nodding her head, right? Right. Or you feel a vibration like I'm right now, because I have a partial pudendal nerve entrapment on my left side. It's starting to flicker right now. I feel vibration. Happens every meeting. That happens all day, every day. I mean, I've been sitting here for 3 hours now. That's what happens. So for these patients, we've got to figure out where and why the nerve is compromised. I know why mine is compromised. My left piriformis muscle is compensating for an SI joint dysfunction, and it is squeezing my nerve on my left side. All right. And so the therapy for this, our therapeutic priority for this group of patients, is going to be to treat the source of the compromise, which is probably tight muscles, and also calm nerves down, which is going to be doing things specifically for nerves like neurontin or neuromodulation, something like that. And then IC subtype 5 is central sensitization. So this is the inherited version of it. And this is also my subtype, because every woman in my family has this. And I talk about this as the landscape. the landscape. This is not a disease process. Central sensitization is either inherited or the result of a traumatic injury. And what that means is that the nerves are more sensitive, not just in the area, but throughout the body. So patients have sensitive skin. We are drug sensitive. We are food sensitive, not just with our bladder, but our body in general. We have a wicked sense of smell. And isn't it interesting, guys? So I remember in 1993 and 1994 that UC Berkeley was studying why BIC patients had a wicked sense of smell. Some, because smell is a brain function. It's like, yeah, but the bladder's not connected to the brain, but the nerves are. And isn't it interesting now that COVID actually changes your sense of taste and smell, which is also about COVID attacking parts of the brain. All right. So with central sensitization, our goal is to calm and soothe the nervous system as a whole, not a disease. We don't treat it as a disease. This is more of the landscape. This is my life. I'm sensitive. I always have been sensitive. I get it. It's not my fault. It's not your fault. You know what? You know what? Listen, I'm going to say this to you. I get hints. I think it's my little guardian angels whispering to me. There's somebody out there right now. I don't know who it is, but I'm looking at you right now. And I need you to know this is not your fault. You have done nothing wrong. There is no shame. There is no blame. You are hurt. You are hurt. And last night, something said, you need to look somebody in the eye and take the shame away. And I'm doing that for you right now. You are not damaged goods. You are a wonderful woman or a wonderful man. And you're hurt. You're hurt. And I know that people beat you up and people cast doubts and doctors cast doubts. Listen, you are not alone. You are not alone, and we're here, and we love you, and we care for you, and we're going to do everything we can to try to help you. And I'm glad I remembered to do that, because it was just like my guardian angel whispered in my ear, look him in the eye. I'm looking at you. I'm looking at you right now who's feeling that way. And you can call me anytime. Well, obviously during working hours, 800-928-7496. I just feel that somebody's going to watch this is going to know what I mean. Okay. Okay. So using the pain subtyping system, it allows us to focus therapies correctly, but more importantly, it allows you as the patient to understand your anatomy more. And that's important. You are the boss. You lead your care. You pay them. They don't pay you. And I don't want you to walk into the doctor's office and say, I don't care what you do anything to make it go away. I'll do anything. Just do it. No, 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 no. You have to be fully informed. We don't want you to go in and have them put silver nitrate in your bladder and strip your bladder wall. It happens. It still happens. It shouldn't be happening. I need you to walk in and be a detective. And your job is to focus your doctors on studying your pelvic anatomy. Over on our website, I've got a list of confusable conditions. You got to rule all those out. Listen, if you're not responding to therapy, if you're getting better or worse, man, you got to take a step back here for a moment. We got to re-examine this situation. We have Sue on Facebook, a very important story to share. She had IC for years, failed every bladder therapy, every single bladder therapy. Nothing worked for her. What was interesting is when she did pelvic floor physical therapy, it always hurt, which is really rare. Normally, when you do pelvic floor physical therapy, you feel better, right? Normally, but pelvic floor, you feel better. For Sue, it always hurt. And she's like, it's like, okay. And I always say, listen, if you got a spot, focus on the spot. She started thinking about the spot that always hurt. And she asked the doctor to do some imaging. I don't remember if it was a CAT scan or an MRI. You know what they found? They found a growth woven through her pelvic floor. It was either a growth or scar tissue. She was a horseback rider. She remembers falling really, really badly on that side. That was the exact side of an injury. So she is an example of somebody whose bladder symptoms were being driven by a clear and distinct pelvic floor injury. and wasted time. They all wasted time, doing bladder stuff. And so wouldn't it be great if we considered all the related conditions first and just tried to rule them out one at a time? You can't do it in one appointment. You're going to be doing this over 6 months. But learn about them. Learn about them. Come over to our website, read about those confusable conditions, because you could have one of those. Pelvic congestion syndrome, treatable easily. Fibroid tumors, treated. We know that 65 to 70% of patients with fibroids have urinary frequency urgency. We also have the research that proves that when the fibroid is treated, the frequency urgency goes away, and that patient is considered cured. Cured. And if you've got a fungal infection, that is treatable. If you have a bacterial infection, that is treatable. If you have a viral infection, it's a little bit more tricky. It's treatable with antivirals, but that infection is going to be persistent, just like herpes is and canker sores and all this sort of stuff. I mean, I get canker sores. It is what it is. Okay, so those are your 5 subtypes of IC. So getting back to Sarah from England, you felt better on an antibiotic. So let's follow that line of thought. If you feel better on an antibiotic, let's see if you got a bladder infection. Have a next generation test. Why not? Got nothing to lose. Go to bladderhealth.org. So Jennifer asked 35 minutes ago, granted this was before, what is the best treatment for IC? It depends upon your subtype. If your subtype's 3, pelvic floor, it's going to be pelvic floor physical therapy. If it is number 4, pudendal neuralgia, it might be finding the source of that nerve issue and treating that. If it's chemical irritation, your bladder it's going to be about modifying your diet and doing a bladder coating. If it's estrogen atrophy, it's going to be using estrogen therapy, perhaps a chondroitin-based supplement, et cetera, et cetera, et cetera. Girl, can I talk? I can talk. All right, hold on a sec. I had minimized Zoom. All righty here. Sally says, I had all the gynecological tests, not biopsies, a lot, all clear, ultrasound, everything. My IC came on after a smear. I was perfectly fine. Okay, so again, Sally, could the smear, could the speculum have introduced an infection? Sure, it's possible, but you got to prove it. Next generation test. Rhonda says, I'm subtype 1. Elmeron did nothing. I tried it for 2.5 years. You're right. Elmeron is a waste of time for Hunter's lesions. Hi, Michelle. Thank you for my birthday wishes. I appreciate that, or your birthday wishes. What's the name of the book? The book is Breaking Through Chronic Pelvic Pain. Here you go. Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Mary Lynn says, happy birthday. Thank you. Fern says, thank you. Fern says, my urogyn just prescribed Valium vaginal suppositories for my pain, but he still believes my pain and frequency are due to pelvic spasm from doing too many Kegels. He said NSAIDs are best. When he did an internal, he hit a spot. I saw stars. He said that is your pelvic muscle. There you go, Fern. Going to town with Kegels. Hey, man, listen. For anybody who has IBS or anybody who's had Montezuma's revenge, and you're stuck in the bathroom with severe diarrhea, and you're spasming. You ever notice that you can't pee afterwards sometimes, that it takes 5 or 10, 15 minutes before your muscles can relax enough for you to let your urine out? That's your pelvic floor spasming. So it'll be fascinating to see what the vaginal Valium does for you, hon. I bet it'll be interesting. Listen, with your pelvic floor exam, be patient. You got to know your stuff. You got to learn about it. You got to read about it. Talk to them. I talked about that a lot earlier. Don't be afraid of pain. If she can touch a muscle and trigger your pain, that is a hallelujah moment. Now we need to know what she's touching. Don't let the pain scare you. If it hurts, that's a good sign. Then at your second appointment, as they're working on those muscles, you're going to be much more gentle. Well, they're gentle anyway. My primary said I should try an oral drug first, hold off on the Valium. Well, yeah, baclofen is a muscle relaxant. That would be okay. But that's not a substitute for a proper pelvic floor exam. A low-dose Elavil, it can calm nerves. It's a hard medication to take. It's got a lot of side effects, dry mouth, heart irregularity, stuff like that. The American Urology Association guidelines says Elavil is a step 2 therapy, whereas they say try the supplements first because the supplements don't have the same reactions. Jennifer is looking to doing stem cells for her bladder. Awesome. Lorraine says stem cells, mixed bag. It'll be interesting. The results, the last study I looked at showed that it lasted about 6 months and you had to have them injected again if you're looking at the Elliott Lander stem cell research. Lorraine says, if your pain is pelvic floor, should you follow the IC diet? The answer is yes, because if your pelvic is screwed up, it's going to compromise your bladder wall. Your bladder wall is going to be broken down a little bit and be more diet intolerant. So yes, you want to follow the diet, maybe not to a great degree, but at least don't do the coffees and the sodas and the multivitamins and the stuff like that. Sally says, what's a diet? Sally, go over to our website, icnetwork.org. You can read the diet there. Stephanie says, diet works for me. Jennifer, the phone number is right on our Facebook page. Just go to the main Facebook page or go to the website for the phone number. Michelle says, is asking about stem cell therapy. We've done several articles on stem cell therapy on our website. Go check it out. The doctor is Dr. Elliott Lander. Mixed bag of results. There are issues with stem cell therapy. David says, do I get something for free? David, what would you like? Hi, Carol. Thank you. Is that a loaded question, David, or what? Jennifer had platelet-rich plasma injections in your pelvic floor, and they've helped a lot. It lasts for 3 to 5 months. Awesome. Thank you, Sandra. Thank you for your birthday wishes. I appreciate it. For instance, my allergist thinks I have mast cell activation syndrome. My urine level showed high histamines. Is there any correlation? Yeah, definitely, hon. If your mast cells are out of whack, your bladder wall is going to be out of whack. So that's absolutely possible. All right, let me go down to YouTube here. Do you think it's safe to go into the doctor's office for a cysto camera test with COVID? I do think it's safe because, I mean, depending upon your state, at least here in my state, they're only letting one patient in at a time. Generally, you get there, you call, or you go to the door, they take your temperature, then they send you back to the car, and then they will call you on your cell phone when to come in. And the sterile technique right now in doctor's offices is pretty dang good. And so, as a friend of mine said who works in a hospital, it says, what did she say to me? Her quote was really interesting, but it was something about one of the safest places you can be is in a medical care clinic that is practicing the ultimate sterile technique. I'm not talking about a COVID clinic or urgent care, but the odds are they're on the ball. Ask them what they're doing. Go ahead and ask them what they're doing and how they're going to protect you. Anne says her birthday is on the 2nd and you will be 74. Happy birthday, Anne. A welcome cancer person. Rhonda says, what upsets me the most is not enough updated treatments are available. I was looking to tell my new uro. All the treatments I found Googling were outdated. No wonder many urologists give up. My new urologist looked like I was an alien when I was trying to explain the 5 subtypes. Yeah, you got to remember that local doctors are not going to know the subtypes at all. They don't, this is new. This is top tier stuff. They don't take classes necessarily, and all the urology conferences are canceled. We've only been doing subtyping for the last couple of years, and it's really only the top tier IC doctors who are doing it. And they're all doing their own systems. I just use the pain system. All right. Oh, thank you, Rhonda. I've known you for a long time. David says, can I get aloe? Okay, so we're going to have a new aloe product called Aloe Path, which combines aloe with PEA. And we've discontinued the Desert Harvest aloe in favor of Aloe Path because I think it's going to be a lot more soothing. And so here's your freebie for the day. If you would like to try Aloe Path, when I get it, which will probably be in 10 days, I will send you a free bottle of Allopath. Let's say I'm planning on anybody who's getting Desert Harvest Auto Refill from us every month or every 2 months will be getting a free bottle automatically, because that's what we're going to transition them to. But here's my offer to anybody here. I don't have the bottle in my hand yet, but we already have patients using it. If you would like to try Allopath, I will send you a free bottle. I will go up to 25 bottles. All right. All you need to do is send me icnetwork@mac.com. Send me your mailing address. Now, we built it in. I mean, I was very, very clear that I knew that we were going to, I wanted to do that. That was my demand. So the company is helping me do that. So David, there you do. There's your deal. If you would like Allo, send me your info. Anybody else out there, if you'd like to try the new Allopath, let me know, and I will do my best to get it out to you. But it's probably going to be 2 to 3 weeks before you get it. So I'm not expecting it to get it until late next week. I mean, late this week or early next week. All righty. All right, my friends. Well, listen, we've been doing this for 3.5 hours. It has been a great birthday. I am so happy to share my birthday with those, anybody else out there who's had a birthday or is going to have a birthday and you're home with COVID. You are not alone. We are here. We love you. We want to help you in any way. Please, I want you to remember your homework. Your homework is for 15 minutes a day, do something for your spirit to give yourself comfort. For 15 minutes a day, do something for your bladder or for your pelvic floor, your exercises, or whatever you need to do. For 15 minutes a day, I need you to read. Improve your knowledge level, my friends. And for 15 minutes a day, I want you to laugh. And if you want Allo, you have to send me an email, icnetwork@mac.com. icnetwork@mac.com. All righty. Okay, guys, listen, I'm going to shut down Facebook, shut down YouTube, hang out on Zoom just for a few more minutes. So I'm going to say goodbye. I wish everybody the best. Be strong, be safe, stay home, wear a mask. We are going to get through this. icnetwork@mac.com. icnetwork@mac.com. All right, goodbye, Facebook. Facebook is gone. All right, YouTube. I'm going to send, there you go. All right.